A very good morning to all. Today marks the 111th Foundation Day of our historic Department of General Surgery, KGMU. With its best-in-class teaching and exemplary clinical learning and patient care, we take pride to be a part of this prestigious department. To mark the beginning of the Foundation Day, we have in line some prestigious orations that will be delivered by the masters of the field. So we would like to start with the prestigious Professor S.C. Mishra oration. I would now like to invite Professor Ramakant to kindly grace the dais. He is former head of the Department of General Surgery, an exemplary person. He is a philosopher and a poet, well known for his surgical and teaching skills. I would also like to welcome Professor H.S. Pava, sir, a senior professor in the Department of General Surgery. He is a known urologist and academician.
Yeah. Hello. Good morning, friends. It's really a pleasure whenever I come back to my alma mater, and especially when you feel that you're going to chair a session of a star. Before I call him, I want to say something about him, but you have written here, I will read it. But for me, it's not required. I know much more than that. Professor S.K. Mishra, actually, he was the head of the Department of Endocrine Surgery, and he is, in my way of thinking, in North India, he should be called the father of endocrine surgery because he established departments and departments. He encouraged people, and to the extent that somehow or the other his influence key reached far and wide, and you find several departments coming up, even including King George Medical University, where the endocrine surgery department is there, and endocrine medicine department also is there. So therefore, what happened, and far and wide, I travel a lot. So I was telling him that it is a surprise that I go to so many places and my students, they meet me and say, sir, madam, what are you doing? क्या कर रहे हो? Sir, endocrine surgery कर रहे हैं. Department नहीं है वहाँ, unit भी नहीं है. But they started doing, and then a stage comes when unit is created. So that way, he is a person who has been very constructive. He is very creative, very adjusting, a real leadership quality of keeping quiet. And amongst all turmoils and those things, he can be as peaceful as ocean, where you find that the things are above very disturbed, but underneath you find a very quiet type of movement. So therefore, I wanted to tell about all that thing, and when I came to know that Dr. Sonkar is kind enough to invite me for this purpose, so I was really very enthusiastic to have this and seen all of you here. And from my side also, welcome to this August gathering, welcome to the oration, and welcome also to the institution from where people from here and from outside. Now, I will introduce and request Dr. S.K. Mishra to kindly come on the dais. And I'll just introduce you in brief so that some juniors are inspired. Seniors are already knowing him, that he is MS, DNB, General Surgery, FAMS, FACS, Senior Consultant and Endocrine and Breast Surgeon, and founder, head, and former professor endocrine surgery at PBI. 38 years of a clinical experience and 1,200 successful endocrine surgery and breast surgery. Founder, head of professor and department of endocrine surgery at SGPGI. And minimally invasive thyroid and parathyroid surgeries, thymus surgeries, surgeries of neuroendocrine tumor, Cushing syndrome, pheochromocytoma, breast and thyroid cancer surgeries, surgeries for pancreas, insulinoma disorder, and diabetic foot surgery. Do you know that he also established the telemedicine department there? And I think he also became the father of telemedicine here, and there is a branch on KGMC also, and several other places. And still at present, on top of that feather, he is being taken by the IIT people, so that he is trying to collaborate the surgery with the telemedicine and also with the innovations. And I'm sure you are aware that there is also possibly department or unit of innovation, that medical innovations in which people are working here, and they have grants and the work is going on, and they have done a lot of things. So with these things, I really pay my heartfelt regards to you, sir, and I'll request you to kindly deliver the oration for Dr. S.C. Mishra. Okay, thank you very much, sir.
Respected chairs, Professor Makant, Professor Power, Professor Sonkar and his team in Department of Surgery in King George Medical University. First of all, I used to like to congratulate the department for the 111th Foundation Day. This is one of the oldest department in the country. I have the privilege to be associated with this department since I joined in Lucknow in 1989 in GPJ. So before I proceed further, I must thank Professor Makant as well as his superior, Professor K.D. Burma, for giving me support to set up the Department of Endocrine Surgery, not only there at GPJ, but also in the King George Medical University. So, Professor S.C. Mishra oration is a very prestigious oration. I have heard about it. Earlier, I gave the Professor P.C. Devi oration in this institute. I can imagine the leaders of those days who have developed the departments in different parts of the country, and especially when there's nothing in terms of the technology armamentarium to develop such kind of technologically innovative departments of surgery. So now, of course, the things have changed. So I have chosen the oration topic, something similar to that, where we started, our forefathers. What was surgery then, what is surgery now, and what is surgery in the future going to be, and what is the surgeon then, and the surgeon now, and surgeon going to be in the future, and the environment, the ecosystem that the surgeons are going to work in the future. So this is very much inspiring for youngsters. I request youngsters to take a lead in this direction and develop this area. Many of these areas are just emerging, and you are these torch bearers, and this is going to benefit directly to our patients. Okay, so let us look at the back and historical background. When the surgery was born in the Neolithic age, as interventional medicine, you know that trepanations are creating boreholes to release the evil spirits, and the procedure that has been documented up to 20th century. The Egyptians and the Susrut in our own country, the Greeks developed scientific principles and surgical technique, trauma care, and anatomy. After the fall of Roman Empire, barber surgeons worked as general interventionists. With the advent of human anatomic dissection, bleeding control, anesthesia, and antisepsis, the last century has seen a transformation in the field of surgery, paving the way for surgeons to successfully perform major operations. Can I request a put out the light, please? Although surgery advanced notably with the magnificent anatomical descriptions by Andrea Vesalius, it has reached its peak in the last 150 years and is still growing exponentially while becoming increasingly more inclusive and complex. Worthwhile to recognize the contribution of great surgeons such as Joseph Lister for antisepsis, Theodore Billroth, Johann van Michelis, George Thomas Merton, Charles McBurney, and in particular William Halsted, who stated that operations in themselves are only a small part of surgical procedure. I'll be talking a little later what this means, that how is surgery is a system, not just a particular procedure. Now, advancement in medical science had profound effect on surgery. Surgeons have traveled a long way from traditional surgery to use of precision instruments like ultrasound to endoscopic and robotic assisted surgery to adopt new technology. In that way, surgeons are very innovative. They explore newer areas, especially in instrumentation. Next milestone in surgery seems to be digital surgery, the digital ecosystem that we are already working now and is going to expand further, which I'll be talking about it, which is the convergence of surgical technology, real-time data, and intelligence. Advancement in machine learning and artificial intelligence are enabling the creation of digital surgical solutions that connect the patient journey before, during, and after a procedure. Conventional surgery is based on subjective experience, while digital techniques bring quantifiable information, transferable data, repeatable methods, and predictable surgical outcomes, and decreasing patient risk. Now, as you know, our specialty of general surgery is in a phase of evolutions. How it has been spreading, and so-called general surgery of 50 years ago has now been fragmentized, super specialized, what you call it, and we as the surgeons always train to offer fellowships and acquire to focus in particular areas. Definitely, that trend has helped to getting the surgery more refined and getting maximum benefit to the patients. However, surgery is still fighting to become a science, a true science. Though based on sound foundations in anatomy, physiology, pathology, while advancing in genomics to understand molecular basis of complex diseases. Those are things that we have seen happening in the last 50 years. Surgical procedures are becoming less traumatic and safe. People are doing endoscopic surgery, minimal access surgery, so this is a proof of that. Measured progress in safe anesthesia, intensive care, nutritional support and drugs, antibiotics, antithrombotic, and coagulants, as well as selective use of blood components replacements. They are all in place now. Advancement in surgical instrumentation, surgical visualization, energy devices, coagulation devices are made surgery safer day by day. Now, what are we going to observe in the future? What the future is going to be? Now, the Royal College of Surgeons constituted a committee and a commission to look at this. The group of very eminent people gathered, did exercise which is published in Nature, and they say that what is going to be surgery in the future and where the technology is going to really make invasion to the surgical field. The future of surgery will bring innovative technologies, enhanced understanding of disease, wider collaboration among experts and innovators to improve patient care. Technologies such as what we heard about 5G, now it is of course available to all of us. Edge computing, surgical robots, the so-called surgical robots of yesterday is getting revolutionized. I'll talk about a little about that. Artificial intelligence, three-dimensional printing, and new imaging methods are already changing and will continue to change the way surgical care is delivered. As you know that three-dimensional printings are being used for congenital heart disease surgery practice before actually surgery is being taking place. The field of genomics, regenerative medicine, and cell-based therapies could open new avenues for predicting and treating diseases which are unthinkable only a few years ago. Now, to explore what technology will make greatest impact, what does the future mean for the patients, now how will the delivery of surgery change and the future surgical team? Let's talk about that. Now, which technology will make the greatest impact? Image-guided surgery already had made an impact, is getting more and more refined, whether it is self-driven endoscopic surgery or a robot-assisted. Precision imaging, big data and genomics, specialized interventions, surgical data science and analytic tools by ML and AL, AR, VR and mixed reality, you know it's for training, 5G and 6G network. Today we are not talking of 5G now, it is now for 6G. Now, high performance computing, where it can process the images faster, where you can see the surgical videos quickly and make analytics on the surgical videos. Then molecular imaging like biofluorescence that is being used in indocyanate green. How will the delivery of surgery change? The future of operation theatre is not what we saw 50 years ago when we were students. Now, of course, you have already seen how operation theatres looks like. So many equipments are never seen in the operation theatre are now in the operation theatre and being operated by the surgeons. Now, what will look different with greater integration of digital technologies? AI could be used to schedule procedures, request instruments, and monitor the environment. Digital systems will offer guidance to OT team and show enhanced anatomical imaging during surgery. Now, will surgery become more locally or centrally delivered? Now, there are thinkings that only complex surgery needs super specialty or centralized tertiary or quaternary hospitals. Rest of things can be mentored to be done in district hospitals. That is the future people are thinking of. Now, enabling and reviewing the innovations are also very important in the coming generation. Now, what does the future mean for the patient? Let us look at that also, because we are here for our patients. Now, how surgery and healthcare will change? In the future, surgery will potentially prevent and not just treat illness. We have enough examples in that. Early interventions and coordinated management of chronic conditions. Less invasive surgery in time to come, more accurate, more predictable outcome, faster recovery, and lower risk to harm. Now, who will undergo surgery? Now, you will find the non-invasive treatments are coming into play. New drugs may cure, not need any surgery. How health and patient journey will change on increasing burden of the non-communicable diseases. Now, the possible risks are very important to know, which brings a lot of psychological impact on the patients as a family. More informed patient, not only by our physician ourselves, but by the so-called resources available in the website. More informed patients, great anxiety and genomics information leading to risk reducing surgery. They did not ask the surgeons, what is my prognosis of my child? They all find it, and all these technologies are available now to Google, ChatGPT, all these things coming up in the near future. Now, technology in current surgical practice that we have, I started in AGPJ, I just like to give some of the pictures to just see. Image-guided surgery using computer vision, robot-assisted surgery, computer-assisted surgery, intraoperative imaging and navigation, fluorescence-guided surgery, integrated digital operation theatre system, and surgical video communication systems for telemetry. So, some of the things you must be doing it here also. So, here we started with the integrated operation theatre, this is design, and this is deployment, and which has been taken 2 iterations from analog video to the surgical video systems, then developing network within the hospital and outside the hospital, reaching out many medical colleges, surgical telepresence suite, and we have developed this tele-collaboration high-tech medical lecture theatre. Many of you must have seen these things at AGPJ. How in the such digital ecosystem, digital surgical ecosystem, what are the challenges we are going to face? Now, maintaining the confidentiality and security of patient data, ethical and technical issues related to generation of this data. Despite strong growth of Indian digital surgery market, the industry is plagued by low penetration due to higher cost maintenance of disposables, training, technical support, and insurance. This is very much applied to our robotic surgery. Healthcare is one of the most common industries for cybercrime. However, making this big data accessible to appropriate stakeholders could lead to the important developments and discovery in medical research. You might have heard about the data protection bills. It's still not being approved by our parliament. So this is have a lot of impact, and day in and day out, all our data are being made available by the telecom companies to different sources. Sustainability is a common concern, so as environmental issue and disposable instruments. Training and skill development of large digital workforce, and safety of patients, affordability, and lack of awareness. So all these are challenges that younger generation have to face in the future. Now, do we need more robots or better surgeons? That is a very big question. I want you to think about that. Because whenever there is a big toy, everybody wants to have the toy, right? Especially as a surgeon, you like to explore new instruments. But what is more important, don't forget, the majority of surgeries needs to be done by expert surgeons. Still, many hospitals don't afford for advanced instruments. So we should think about also surgeons. Now, what should be ideally attributable factors for scientific surgeons? Now, maintaining a solid academic education, there our role comes in. Seeking the truth in medicine and surgery, basing themselves on scientific method, developing clinical basic and applications to surgery, and generating proofs. Generating schools of surgical knowledge and research, being innovative and creating patents, studying for their whole life, governing themselves by ethical and moral values, being committed to patients, society, and themselves, and being a leader. Now, the learning and technological training strategies also you have to develop, which should be student-centered teaching. Nowadays, more self-directed learning are in the vogue. There are many sources of knowledge available, especially for surgeons. Skill-based study plans, problem-based learning, evidence-based medicine, basic clinical integration, and moreover, we have to be very proficient in medical computing and also the so-called remote medicine. Now, a new approach has to be taken for surgical training. Throughout the history of modern surgery, training has been accomplished as a one-to-one apprenticeship in the operating room. High-volume surgical training programs offer the best opportunity to see surgery and experience rare cases. But the challenge is most surgical training programs only take a handful of applicants per year. And in addition, what is happening nowadays in our country, the number of residents have been now increasing disproportionate to the infrastructure and the trainers available in the hospital. And I had one of the prestigious institutions, even the surgeons in training have not been getting a hernia to operate during their training programs. And even the more kind of joke for me, the faculty told me he doesn't know who is this person when they go for exams. So that kind of things, where 70 or 80 people are there at a particular point of time in a department. Would it be possible to expose surgeons in training to complex procedures regardless of location, background, or access to the world-class mentorship? Is telemedicine, telesurgery the answer to democratize the surgical learning and bring the best surgeons to communities around the globe? Imagine the ability to take expert surgical knowledge and share it with colleagues and trainees anywhere in the world on demand real time. These are all possible. It's a question of mindset. Somebody has to lead this thing. You have enough of facilities now available. We have AI channel, we have MedTube, so many things are available nowadays free of cost for surgeons. Now many of the surgeons in practice, they look at the YouTube, then come to do the surgery. So this is all in the vogue now. Now the surgical training goes virtual. You might have heard about the head-mounted display. You have got all the sources in the handphone to use it to get trained yourself in different kind of surgeries. The concept of surgical training has changed in the information age. Tomorrow it follows the Halcyon legacy, see one, do one, and teach one is no more relevant. Put on a VR headset, pull up the case from the library, the resource library. First watch the operation being done from the surgeon's perspective. Commentary and annotations of the anatomy are overlaid for your learning, and you observe so on and so forth. These are all kind of available. You might have tried yourself and seen it. This is the thing that we did a couple of years ago at GPJ when I was there. So telementor using the tablets in the operation theaters. So step by steps telling the trainees. So these are all possible. Your technology permits that thing to do it. Nowadays being 5G is available everywhere. You can jolly well see such kind of situation will be there many of these medical colleges where you can connect to the peripheral hospitals and train people. This is just a device you require in the operation theater. Moreover, what I hear is that a number of medical colleges in this particular state, around 52 medical colleges. I think in that context, all these old medical colleges have responsibilities to look at this aspect, to how to train the surgeons in the periphery. Now, how to think the future surgical team, everything, we need the support of many of your colleagues from diverse disciplines. Let us look at this. The role of the surgical team, the multidisciplinary and multi-professional surgical care team now. Surgical teams will work along the bioengineers, geneticists, the molecular biologists, data analysts, transplantation experts, and other expert disciplines. The evolution of the role of the surgeon is likely to depend on the best treatment options for the patients. Naturally, many minds got together. Surgeons will now be multifaceted to collaborate with medical, genetics, radiotherapy, and bioengineering. Now, how the changes are expected in the training programs? The flexible training curriculum, knowledge of computing, engineering, molecular biology, data literacy, leadership, team building, and communication, which we never teach to our residents. We should think about this. Training in new technologies like data analytics, augmented reality, virtual reality, mixed reality, etc. These are very helpful in skill training, remote mentoring, and proctoring. Now let us look at my last part of this oration is how the surgical workplace or the surgical digital ecosystem looks like in the future. We have to prepare ourselves. Many things I have not included because of shortage of time. I'll give you an overall kind of bird's eye view how the things are happening. As you know that in the society, how the technology has come in. You have heard about industrial revolutions. So if we compare industrial revolution from 1 to 4, that exactly translates to our surgical evolutions also. In the first evolution, industrial revolution, you have mechanizations, steam powers, locomotives. In the second, you have the technological revolution, mass production, assembly lines. In the third revolution, we found the digital revolution, the computers, automation. Now it is all information-based. These cyber physical systems, we call the metaverse in surgery, applications, artificial intelligence, Internet of Things, big data analytics, blended educational technology, 3D printing. So if you see all these things, it culminates to the surgical environment. You find here the surgery one, stage 1 is open surgery, then of course 2 laparoscopy surgery, then 3 is the robot assisted remote control systems. Now in the 4 we are going through now, it's called the surgery 4.0 or digital surgery, is information based intelligent robotic surgery. Is going to different generation robot, where robot is instead of following your commands, also giving you advice. That means that kind of intelligent analysis, it can do it, and it becomes a cognitive assistant, surgical assistant to you. Now, if you look at this slide, where you'll find how it is being happening here in the century-wise from 1900, now in 2050. So, end is the digitization surgery, and it has gone progressed in that way. As a surgeon, you can understand from the anatomical basis of surgery, now it is going towards digitalization, where we are heavily dependent on technology. Now, the concern always on us, Many things people say that, the robots are going to take over. If the pathologists see that the artificial intelligence will remove the job of the pathologist, radiologist, that's not true. Ultimately, nobody can replace nobody. Definitely, if you are not trained with AI, then you may be replaced. Because you have to understand the data, you have to understand the analytics. So here, will the machine take over surgery? Answer is big no. Now, what is going to be there? It is a synergy. The synergy between man and machine for better surgical outcome. You are facing difficulty to operate in the pelvis, your robot arms helps you to reach at those inaccessible areas. You want to do anterior resections, going to the pelvis is difficult, you can do it that robotic arm. So those are things, but overstretching these things, taking a robot to do a hair transplant, that is too much to think about it. So you have to restrict yourself where you really need a technologist to support you. Now this is another situation. This is a very fresh slide. I just want you to, for information, how these technologies are going to be in operation theatre. You are going to be surrounded by these technologies, and you have to accept it, you have to learn it. Without that, you will be definitely facing little difficulties. So surgery 4.0, that is corresponding with Industrial Revolution 4, you have the big data, you have remote assistance, you have the 3D simulations, you have integrations. We need to get the all images. You can reconstruct the surgical images. You can reconstruct the patient's own anatomy. So you make a custom design. You can do it preoperatively. You can make a hepatic tumor reconstruction in your office by the help of technologists and do a virtual surgery on the computer before you go into the operation theatre to operate. So you exactly know what difficulty you are going to face. If you custom made patient models, you can do it. So these are the technology that is going to come up in the near future. And your intelligent system that is going to happen with the robots. The robot that we see today is going to take a different role in the future. Now we've got flexi robots coming up. So intelligent robots are coming up. So you have to prepare for those things. They are very, very highly intelligent. Now again, I'm summarizing. The Industry 4.0 will have so much of role to play in surgery in terms of interconnections with relevant sources, relevant resources, giving technical assistance, giving information, transparencies, and decentralize some decisions. So you can remotely guide it by somebody in somewhere. And other things also you should know that how the image-guided surgery is coming up, the navigations are also coming up, and hybrid theatres are coming up. Already the operation theatres are going very, very revolutionized. It's very expensive, but at least hospitals like KGMU and other leading hospitals should have such kind of facilities where you can have intraoperative investigations and surgery together, especially very important neurosurgery, where there's a rail and the table can be slided to the MR and come back and do the surgical steps, clearance of a tumor. And navigation is very important for us in cases of breast cancer and other surgeries, so to have accurate localization of the tumors intraoperatively. Another thing I like to bring you just for your reference, artificial intelligence is there very much in the operation theatre. There are products available there. They will tell you actually, the gallbladder surgery you are doing, you are facing a problem. The continuously camera is monitoring it, and they're telling you, stop. This is not the way it should be done. There are already prepared images of similar kind of thing. Based on the pattern recognition, they'll tell you, this is the situation, and you should operate this way. So this is already there in the market product. So you can imagine where the technology is taking us. Now to conclude, the digital surgery is coming up as a disruptive force in the healthcare system, especially in surgery, has the potential to transform standard of care by delivering better outcome, reducing invasiveness, resulting in faster recovery time and a lower cost of care. Though the most exciting and sophisticated advances are in operating theatres, relatively simple smartphone technology is said to have positive impact on patients before and after operations takes place. I didn't actually cover a lot of things. We have done a lot of work in the social media, in surgeries, tele-follow-ups and all those things, very relevant to our country with poor financial status. So you can follow up your patients. You can discharge the patient early, cut down the hospital expenses, and you can jolly well take the maximum advantage of the advancing broadband high-speed internet. This will really make you remain connected to your patient. Follow-up is a big problem in our country. Please use the tele-follow-up, ordinary social media. Now the common man is very techno-savvy. The coming generation that we are going to see, they are playing with the mobile phone as soon as they are born. So you see that kind of consumers you are getting it. You can do really miracle things in the healthcare. Now 3D planning and printing technology are likely to become very widely available. You can really operate a patient on 3D models before going to the theatre. However, on the whole, patients should be able to expect less invasive and more accurate surgery in the future, with faster recovery times and smaller differences in the performance between surgeons. Mark the last sentence. smaller differences in the performance between two surgeons. That means our responsibility to see that all the surgeons are competent. They are safe surgeons that are delivering the best care to the patient. I'll end by quoting the prophecy of Halsted. All of know William Halsted is a very reputed surgeon. It's a tremendous impact in the training of the surgeons. What he said, operations in themselves are only a small part of the surgical procedure. We need a system which will surely achieve to produce not only surgeons of excellence who stimulate young doctors to study surgery and commit all of their energy and life to increasing the knowledge of surgical science. Thank you very much for your kind attention and giving me opportunity to present all of you to Professor S. A. Mishra or S.
Thank you very much, Dr. Mishra. You really delivered a very difficult topic, and to the extent that I can say, really, it was just like, if I want to say in Hindi, कि आओ चलो तुम्हें आसमां दिखाएं, because you have shown what can be done, what will be done in future. So past, present, and future. When somebody talks, it is really illuminating, and we are very grateful for your excellent talk which you have delivered. And now I'll request this master of ceremony to conduct further. Sorry.
Thank you very much for enlightening us with this wonderful oration, like giving us a future, glimpse of future, how this we are going to, how changes are going to take place in surgery, and how it is going to affect surgeons, how it is going to affect patients, and how things will evolve. So this really wonderful talk, and I think it is very important to understand it is future, like what sir mentioned for our residents. I would like to emphasize again, its future is for how we should go ahead. So it's all together, all things are going to change. Its future is for teamwork, and you are supposed to transform yourself. So you can say the 3 T's: technology, team, and transformation. So cycle of learning and learning is now very fast. So thank you very much, sir. Thank you.
Sir, actually, Dr. Sonkar, head of department, he told me that the felicitations will be done in the main inauguration hall, not here. So that will be grateful. And यहीं होगा ना, but ठीक है, that's fine. It will be a bigger forum. ठीक है, thank you very much.
Sir, please stay back on the dais for the next oration. So please. Thank you, sir, for the compendious lecture. I request the chairpersons to stay.
Actually, Dr. Sonkar has ordered that I should continue to introduce another illuminating and a very famous person from, I think, PGI Chandigarh possibly, na? That's what I understand. So, dear friends, now we will be letting you know about something to inspire you. That Professor Nileshwar Kaman, he is MS MRCS, PhD. He did his pre-university education from Cotton College, Guwahati, Assam, India. Did his medical school training, MBBS from Assam Medical College, Dibrugarh, Assam, India. Did his masters in surgery from PGI Chandigarh, and did his membership of Royal College of Surgeons, MRCS, from Ireland. Did his training of hepatobiliary and liver transplant surgery from Germany, South Korea, United Kingdom, and USA. Did his Doctor of Philosophy in surgery from PGI Chandigarh, and he is professor since 2012. More than 90 publications in peer-reviewed index journal, and more than that, which I want to compliment him, is that he's got a fantastic appearance. And honestly speaking, when I was talking to him, I was hesitating in talking to him in Hindi, because I thought possibly he has more of appearance of a Japanese. You can't guess his age, I can tell you. Thank you very much, Dr. Kaman. Please, welcome to kindly come and deliver. And he will deliver another important topic, which you will be really pleasant, will you listen. And my co-chairperson, Dr. Pahawa, he is sitting here, and he also is the same, I think. And then after his lecture, he will speak to you. Please, sir, go ahead. Thank you very much.
I Any? Okay. Good morning, ladies and gentlemen, and thank you, Mrs. Chairman, for your kind introduction. Okay. At the very outset, I'd like to thank my friend, Dr. Sonkar, the present head of the department of this prestigious medical institution. And ladies and gentlemen, it is a great honor and a privilege to be here to deliver the prestigious Dr. P.C. Dubey oration today in the morning. Personally, I did not know Dr. P.C. Dubey, but once this oration was allotted to me, I tried to find about him. And what could I find is Dr. P.C. Dubey was a distinguished surgeon, visionary academician, and a fine gentleman. So it is an honor to be delivering this oration in memory of that distinguished person. So today I'll be speaking something very close to my heart, that is the surgical management of cancer gallbladder. It is very close to my heart in the sense because my field of interest in surgery is mainly hepatobiliary pancreatic surgery. And moreover, the place where I practice my art and craft of surgery, it is in the North India. The cancer gallbladder is epidemic, if it is not if it is endemic, if it is not epidemic proportion. Every one of you must be facing the difficulties of treating cancer gallbladder. I know oration is meant to be given on a subject of surgical perspective. My previous speaker, Dr. Misra, who is my senior, we are from the same medical school, PGI Chandigarh. He has done that job, I think. But my talk will be a bit of technical and to some extent more or maybe philosophical. So I will take you the journey of surgery of cancer gallbladder, what has happened in last 100 years. So exactly 100 years back, 1924, this philosophy existed for cancer gallbladder, and this philosophy was propagated by none other than Dr. Blalock, Alfred Blalock. Most of you must have known about him. He does not have any introduction to surgical community. He said in 1924 we are talking about, in a malignancy of the gallbladder, when a diagnosis can be made without exploration, no operation should be performed in as much as it only shortens the patient's life. Today we are in 2023. Definitely there has been some changes has happened in the management of cancer gallbladder, especially surgical management. But nothing much has changed. So, if you look at the natural history of cancer gallbladder, you will find it is repleted with extreme nihilism. And for last 100 years, we could have done better, but we are not able to do better. So this nihilism that was associated with management of cancer gallbladder, especially surgical management, for a surgeon, it was for various reasons. The most important reason was cancer gallbladder has got very aggressive tumor biology. Then the patient status is most of the time they're compromised when they present themselves to you or to the hospital. And there is a delay in diagnosis. Then there are lots of complex surgical procedures are needed to do an R0 resection that may not be always possible. and of course the non-response to systemic therapy, and overall a very poor prognosis. So all this factor has led on to a extreme nihilism, and this was reflected in all the major series that I experienced from all over the world, including North America, Europe, Australia, New Zealand, and Far East of Japan. And at that time, if we are talking about 1970s and late 90s or early 2000, the overall 5-year survival was less than 5% for any stages of cancer gallbladder. But it cannot stay like that. Fortunately, there was a change in the wind. That was a dark age for cancer gallbladder management last century. But there was a change of wind, and there was a ray of hope in early 2000 or late 90s. And this change of wind was coming from the land of sunrise, that is Japan. The Japanese people have taken it as a personal issue, and they started doing surgeries, including stage 4 cancer gallbladder, and they started reporting extraordinary results. They reported up to 30%, 25%, 5-year survival, including stage 4 diseases. So, what was the cause of that kind of change? The concept was changing. Like you apply radical surgery, aggressive surgical approach, including major liver resections. So definitely that has changed the surgical management to some extent, especially Shimujo and Nimura's group. They started resecting stage 4 disease also, and they could show us that 5-year survival in even stage 4 diseases was around 10%, which was extraordinary for cancer gallbladder. And later on, this was again substantiated by the experience from United States of America, Memorial Sloan Kettering Group, that was led by none other than Henry Blumgard. So amongst all this chaos and all this nihilism, what was the Indian connection of cancer gallbladder? In India, worldwide, we have got the highest incidence of cancer gallbladder that was reported in 2006. When an epidemiological study was done for world over, and it was reported that we had the highest incidence of cancer gallbladder. We had 21 cancer gallbladder patients per 100,000, that is 1 lakh. That was in comparison to 7 in Japan and 2 in United States of America. So you can see the patient load. That's a real problem as a surgeon to us. So what are the different procedures that is done for cancer gallbladder and how they have evolved? As I said, since the time of Alfred Blalock in the 1920s, by 1950s, the surgical procedures for gallbladder cancer was standardized to some extent, and the credit goes to a gentleman named Dr. Glenn. So Dr. Glenn was in 1950s, he was the first person, he coined the terminology radical cholecystectomy. The radical cholecystectomy, the meaning is there is an en bloc resection of the gallbladder, the part of the liver in the gallbladder fossa, and the regional lymphadenectomy. So that was the first instances that something was being standardized for this dreaded disease. Then over a period of time, till 1980s, it was a standard of care. Then the Japanese people, as I said, they started doing more aggressive surgeries. Then they started the terminology of extended radical cholecystectomy to denote that you do a more extensive lymphadenectomy along with extrahepatic bile duct resections as a routine also. So that is extended radical cholecystectomy. And regarding liver dissections, even today we are not very sure how much part of the liver has to be excised, whether it should be a wedge resection of the liver or whether it is a formal hepatectomy, segmentectomy, or extended hepatectomy. But by and large, our own practice, and including most of the surgeons will agree, wedge resection of 2 centimeter non-neoplastic liver tissues is good enough. Because if you go into the nitty-gritty and technicality of doing a segment 4B and 5, always it is not possible. That you have to understand. And regarding the lymph node, it is an integral part of your radical cholecystectomy. And the lymph node groups are cystic lymph node, pericholecdochal lymph node, superior pancreaticoduodenal, celiac, and aortocaval and mesenteric. Even after diagnosis, there is some areas of controversy that has not been settled yet. It keeps on disturbing us how to proceed even after the diagnosis. The two moot questions that arises is who should have an operation, and second question is what operation should be done in cancer gallbladder. Coming to the first questions, who should have an operation? It is definitely decided by the disease at presentation, and that is the TNM stage of the disease, AJCC TNM staging, clinical staging. The T stage will define or decide the course of your next course of your action. And of course, don't forget about the patient. The performance status of the patient is of paramount importance. Many a time you will find it is a resectable disease, but the patient is not fit. The performance status is not there. And you end up doing a massive resection and you come back and tell that I have done a R0 resection. But because patient was compromised, patient will not get up from your surgery. So what is the use of that kind of situation? So evaluation of the performance status of the patient is of paramount importance. And what operations should be done? It is an area of controversy that cannot be settled so easily. Radical cholecystectomy or extended radical cholecystectomy, hepatectomy, whether it should be a wedge resection or whether it should be a segmental resection, or whether you want to add on an extended hepatectomy. Same with the lymph node dissections, whether you want to do just a locoregional lymphadenectomy or extensive lymphadenectomy. And what about the en bloc resection of the surrounding organs? That is also not settled. But these decisions are made on the basis of the patient, disease status, and the expertise and experience of the surgeon. That has to be taken that way. Then, as I was mentioning, before embarking on a surgical management of cancer gallbladder, the clinical staging is very important. That we do depending on the AJCC, American Joint Committee for Cancer TNM staging. And just for the record, from my junior colleague, benefit of them, I just want to mention here, it has been staged from T1, T2, T3, T4. And T1 is again divided into A and B. Recent 8th edition of TNM gallbladder cancer has also divided T2 into T, A, B, A and B. That you have to go back and see. So what is T1A cancer? The cancer is limited to the lamina propria. T1B is cancer extending up to the muscularis propria. T2 is perimuscular connective tissue involvement, but that is not beyond the serosa. And T3, it perforates the serosa and invade into the liver or one adjacent organ. And T4 is the multiple organ involvement, more than 2, or if it is specifically infiltrating into the hepatic artery or the portal vein. So this is very important. This TNM staging of cancer gallbladder is very important before you decide for some kind of surgical resections. Then if we look at the different surgical procedures we do for cancer gallbladder stage-wise, in T1A, it is a simple cholecystectomy. Whether you do it laparoscopically or open, both are sufficient. Disease-specific survival after simple cholecystectomy in T1A diseases 100% reported. Most of the large cohort studies has been able to show that. So if you find something like this, then I think simple cholecystectomy will suffice. But the problem is the incidence of this early and curative stage disease is very rare. If you look at the SEER data, that is a surveillance epidemiological end result from United States of Cancer Registry, the incidence is less than 10%. That is a problem, but they are definitely curable. Coming to T1B diseases, it is the most controversial area of cancer gallbladder management as a surgeon. Many of the time, incidental cancer gallbladder will be detected and they will come to you for your opinion. That time you have to make a decision whether you want to intervene more or you want to leave it that way. But most of the authorities has recommended in T1B radical cholecystectomy because retrospectively they have analyzed if they have done a completion radical cholecystectomy, there was a in the gallbladder bed up to 50%. And another important thing is the incidence of lymph node involvement in T1B. It was up to 25%. So current NCCN guideline, National Comprehensive Cancer Network guideline says in T1A, simple cholecystectomy, and T1B, radical cholecystectomy. Coming to T2 gallbladder cancer, there is not much controversy here. Somebody at a T2 cancer gallbladder, radical cholecystectomy is mandatory. Here is a situation where there is a window of opportunity for cure and long-term survival in this dreaded disease. So grab that opportunity, do a proper radical cholecystectomy and hope for the best. The 5-year survival has been shown to be 90% after radical cholecystectomy as compared to less than 40% if you do a simple cholecystectomy in T2 diseases. Then coming to T3 diseases, it is still amenable to your radical resections, but there will be definitely going to be more morbidity and even association of mortality. Extended hepatectomy, pancreaticoduodenectomy, and multi-organ resection might be needed if you want to have a R0 kind of resection. So definitely striking a balance between your technical outcome and the long-term oncological outcome has to be decided, and you have to act accordingly. The Japanese people have been able to show up to 40% 5-year survival after radical resection in cancer gallbladder, that is T3 stage. Coming to T4, by and large, usually they are not amenable to surgical resection. And even if you do surgical resection in this situation, it is associated with significant morbidity and mortality. Hepatectomy, pancreaticoduodenectomy, multi-organ resections. If R0 is possible, if there is no distant metastasis. Of course, as I said, striking a balance. And Japanese, especially Nimura's group, have been able to show more than 10% 5-year survival in stage 4 disease who underwent a R0 resection. That is quite encouraging. So this is the summary of what I have spoken. This is the type of surgery recommended according to the stage of the diseases. So I have already mentioned everything, so I am not going into the nitty-gritties here. So I will go to the next slide. That is the other additional surgical consideration when you are doing a surgical management of cancer gallbladder. Why lymph node dissection is so important and an integral part of your cancer management or surgical management of gallbladder cancer? Because lymph node is the commonest route of dissemination of cancer gallbladder. And doing an adequate and optimum lymphadenectomy is required for an accurate staging and prognostication. That is very, very important. Because there is a direct linear correlation between the stage of the disease and lymph node involvement. Sorry. Like in T1A diseases, the lymph node involvement is up to 2%. T1B, it significantly goes up to 25%. So that is one of the indications of doing a radical cholecystectomy in T1B disease. And T3, it is up to 50%, T2, and T3 up to 75%, and in T4 it is almost 100%. So that you have to realize. That is the reason why we are so sensitive as a surgeon to integrate an adequate, optimum lymphadenectomy when we are doing a radical resection of cancer gallbladder in curative intent. Then regarding bile duct excision, it is not routinely done most of the time in radical cholecystectomy. But if you are doing it as an extended radical cholecystectomy, yeah, your extrahepatic bile duct has to be resected. And it may be required to do a R0 resection. And it is definitely indicated in those situations where the tumor is involving the extrahepatic bile duct. There is a positive cystic duct margin on frozen section during your primary surgery. And of course, those patients who are associated with abnormal pancreaticobiliary duct junction or choledical cyst, or it can be done to facilitate an adequate lymphadenectomy or a vascular resection. But definitely there is no doubt about that. There is increased morbidity and mortality after these procedures. And port side metastasis, you will be encountering this situation as you grow up in your own profession. You start practicing more and more this kind of surgeries. And this phenomenon has been coming into existence, particularly after the emergence of laparoscopic cholecystectomy. it is associated with incidental cancer gallbladder, and by and large they will present as a port-side metastasis. The exact cause is not known, but carbon dioxide has been implicated, the pneumoperitoneum, to some pathogenesis of this situation. Port-side excision does not cure the patient. It can only give you some kind of additional staging information. And once the port-side metastasis happen, the median survival is less than 1 year. So it is an indicator of bad prognosis. Coming to diagnostic laparoscopy, yes, it has got a place in management of gallbladder cancer as a surgeon, because it can identify the inapparent peritoneal metastasis, diaphragmatic nodules, or liver nodules. But routine diagnostic laparoscopy in a resource-constrained country like us is not always justifiable. That you have to understand. And the guideline and recommendations are not very clear. It is up to the discretion of the operating surgeon. So, ladies and gentlemen, after this background, I will just try to present my own experience for last 10 years. I will not say I have done great, but definitely we have made some progress and made some kind of standardization of the surgical technique in our own practice. So this is like for last 10 years we tried to analyze the data, my own practice, my own unit, 2008 to 2018. Like we wanted to see minimum 5 years of follow-up. Follow-up is a big problem in our setup. I don't know about KGMC Lucknow. I don't know about Dr. how Dr. Sonkar is managing it. But honestly, I'll tell you, we are not very good in data keeping, and our patients may not be also very good in their follow-up. So within the time frame, we saw around 430 cases of cancer gallbladder of different stages that present to our unit. And out of that, we are able to resect 120 odd patients, 126 patients precisely. And out of that, we lost to follow-up was around 22 patients. We could not trace them, or they could not came back for their follow-up. So 104 patients were included in this analysis. There was a female preponderance, definitely. Median age was 56 years. And one of the important things we found that, presence of jaundice was up to 30%. Conventionally, you must be knowing, presence of jaundice in cancer gallbladder is sine qua non. That means it is irresectable. That is the concept. That is the nihilism associated with jaundice in cancer gallbladder patient. But we found that this is not the gospel truth. Even with jaundice with cancer gallbladder, you can resect them if you choose your patient well. And clinical TNM, definitely stage 3. Most of the patients were stage 3, up to I think more than 56%, 53% precisely. Then what are the radical procedures we perform is radical cholecystectomy was the most common, up to 60%, followed by extended radical cholecystectomy. And we did 12 hepatico-pancreatico-duodenectomy for cancer gallbladder. Then we had a significant numbers of patients who had morbidity, up to 40%. Patient faced some kind of morbidity. The most common were SSI, bile leakage, hemorrhage, abdominal collection and sepsis. and up to 30% of the patient requires some kind of intervention radiologist or from the endoscopist. And we have to reoperate around 6 patients, and we had a significant mortality. It was almost 10%. 9 patients died. They are in hospital death we are talking about. So it is quite significant and distressing. Then we try to analyze the resection rate from the pathological information, from the histopathology report. And we are surprised to find that we are able to do R0 resection in around 65%. That is one of the encouraging things. And when we correlated the histopathology final, again the stage 3 disease was the most common. Then we wanted to analyze the overall survival according to the R status of the surgery. So we found that the 1-year overall survival was 76%, and the 5-year survival was around 8%. This is the overall group, 104 patients we analyzed. And again, sub-analysis was done. What was the survival of the, according to the resection status, R0 and R1. If it was a R0 resection, the 1-year survival was up to 88%, and 5-year survival was 12%. This was including all stages of the diseases. And if it was a R1 resection, microscopically positive margin, we did not have any 3 or 4 or 5-year survival in this situation. Only 20% 3-year survival and 52% 1-year survival. So surgical resection is very important. The intent to cure should be there, but in action, you should be able to do a R0 resection. This is the plot diagram that was already I have mentioned. R1 resections, there is no 4 or 5-year survival. But if it is a R0 resection, the 5-year survival is around 12%. Then coming to the survival, depending upon the stage we try to analyze, it was showing if it is a stage 1 disease, the 1-year survival was 91%, and 5-year survival was around 50%. That is in comparison to stage 3 diseases. There was no 5-year survival in our series, at least. And the 4-year survival was 7%. And in stage 4 diseases, there was no 4 or 5-year survival. We had a survival of 3 years in 14%. 2 patients survived out of 14 stage 4 diseases. So this is the plot diagram again. It has been already discussed. So ladies and gentlemen, this was the experience in a comprehensive manner. So now I will show you few of my individual patients, what we did, what are the surgical procedures we did in those individual patients. So here is a 50-year-old male. We did a radical cholecystectomy for early cancer gallbladder. He presented with pain abdomen for 6 months. On ultrasound and dynamic imaging of CT scan, there was a polypoidal mass in the fundus of the gallbladder. So clinical TNM was T2N0M0. So we did a radical cholecystectomy. The final histopathology came as adenocarcinoma gallbladder, 0 out of 8 lymph nodes were positive. So P T2N0M0. So this is the slides you can see there. On the upper panel, there is the CT scan. You can see a polypoidal mass in the gallbladder fundus area. So we did a segment 4B and 5 resection along with the gallbladder and the lymphadenectomy. And this is the cut-open section that is corrupt. And she came to our OPD with a biopsy report of gallbladder cancer. Stage was T1B. So what we decided, after investigations, we decided we'll do a completion radical cholecystectomy. So completion radical cholecystectomy was done with lymphadenectomy. Surprisingly, the HPR showed there was no residual tumor in the gallbladder bed. But there was one lymph node positive out of 12 lymph nodes. So the stage was PT1, BN1, M0. So here is the intraoperative picture. The upper panel is showing the hepatoduodenal area. Then this is the resected specimen of the gallbladder, the segment 4B and 5, along with the lymph node. So he had extensive lymph node there in the porta hepatis and the second echelon lymph node, and you can see the clips that was from the previous laparoscopic cholecystectomy surgery. So this is the final picture. So another patient of cancer gallbladder, it was a locally advanced cancer, where we end up doing a right extended hepatectomy with right portal vein embolization for cancer gallbladder with hilar block. It was a male patient, 45 years, presented with obstructive jaundice. His bilirubin was 35 pre-operatively. On evaluation, we could find from the dynamic imaging, he had a mass in the cancer gallbladder neck, and there was no metastasis. PET scan was also done, and so clinically T3N0M0 was given. But the problem here is, when we are doing a major liver resections, you have to know that it is not a simple procedure. It is a different ball game from pancreatic resection, obstructive jaundice. Obstructive jaundice is liver resection. It is a totally different issue altogether. That you have to realize. Then, because then we calculated the volumetric, the FLR, fusor liver remnant. It was very small because it was a type 3A. That means the tumor, the infiltration was toward the right ductal system. So we have to excise the right lobe of the liver along with segment 4. So FLR was that the lateral segment of the liver was that segment 2 and 3 was only 24%. So in that situation, it was fraught with danger. So how we increased that FLR? We did a left-sided PTVD and a right-sided portal vein embolization. And we prayed to God very hard that he does not develop metastasis in between, because it takes some time. 4 weeks or 6 weeks of time is needed for a hypertrophy of the opposite side.
Dr. Kaman, I think you'll finish in a few minutes.
I will take 5 minutes.
Okay,
I'm
thank you.
Sorry.
Sure.
Okay.
Thank you.
Okay,
Thank you.
so then we did a right extended hepatectomy here. You can see the, this is the left lobe of the liver. This is the segment 2 and 3 bile duct. Then we did a hepaticojejunostomy, and this is the resected specimen, you can see. And that is the left of the liver after 4 weeks of surgery. It is hypertrophied to significant extent. Then another patient of cancer gallbladder, where we have to do a hepatico-pancreaticoduodenectomy for duodenal and pancreatic involvement. Here also you can see, this is the hilar block there. Here we did a hepatico-pancreaticoduodenectomy, that is the specimen, and the liver resection and the pancreaticoduodenectomy resection part. So, Mr. Chairman, ladies and gentlemen, coming to the summary of my experience, gallbladder cancer is more common in old age and female patients. Usually they present in advanced stages, that is stage 3 diseases. And radical and R0 resection is feasible and should be done if possible, but it is associated with significant morbidity and mortality. Acceptable overall and long-term survival is possible definitely, and this survival is influenced by R status and disease status. Optimism should replace nihilism. Just wait. Just before completing my talk, I again want to share one of the philosophy of surgical oncology, which is intricately associated with cancer gallbladder. And this philosophy was proposed by Black Cady, who was a professor of professor of surgery in New York. And he said, as a surgeon, if you are dealing with a cancer patient, for that matter, any cancer patient, that you should realize the tumor biology is the king. He will decide what happens to the future course of the patient. Patient selection is the queen. That is the performance status of the patient so important. That is in your hand. Biology, king is not under your control. Surgical maneuvers are the prince and princesses. What kind of surgery? Radical cholecystectomy, extended hepatectomy, that is in your hand. But occasionally the prince and princess try to overthrow the powerful forces of the king and queen, sometimes with temporary apparent victories, but usually to no long-term avail. We keep celebrating. I have done a R0 resection. I have done a hepatopancreatic duodenectomy. That is to some extent, yeah, fine. The patient will live for some disease-free survival will be there. But ultimately, the king will come back and he will claim his territory and kingdom. That you have to remember. But it does not mean that you should give up surgery or you should not be doing anything for that matter. That is the challenge of defeating that king. That is my motto, and that should be your approach. Of course, the queen has to be taken into confidence and consideration. Thank you. I'm so sorry I overextended my time limit. I apologize for that.
Thank you very much, Dr. Common, and you really have shown those things which were, although I am not a hepatobiliary surgeon, but then I am really understanding. And the last thing ultimately comes to
Surgery, KGMU. He is an exemplary clinician and a teacher. I also request Professor Apul Goyal sir to kindly grace the dais. He is a professor in the Department of Urology in KGMU. He is an excellent urologist. I would now like to request the chairpersons to kindly introduce the speaker.
Mr. Anish Srivastav, MCH Urology. Annual conference at North Zone Urological Association of India. Chairman, Board of Education, Urological Society of India. He has delivered
the testicular pain in such patients in the post-operative period. And that is where a detailed study into the parasympathetic and sympathetics which go along the external iliac artery and common iliac artery, we realized that if we cut the ureter a little too low down, and that is where probably these sympathetic and parasympathetic system is affected, and that leads to a kind of referred pain. So we modified our practice. Then these are some of the interesting pictures where we learned that the CT angio, because before that there was the anatomy with the CT scan, and now with 3D CT scan you have a very good picture of the donor, an entire renovascular anatomy before you as a good roadmap. So these are some of the pictures we saw, double IVC also, and how to tackle them the laparoscopically, circumaortic veins, which is the vein which is going from the renal vein and then draining into the IVC across the aorta. It's kind of garlanding. So a lot of new venous anomalies, arterial variations, all those things we learned along the journey, and then how to tackle them. These are some of these pictures which are showing that. And so basically the idea was that laparoscopic donor nephrectomy could be done not only in those patients who had a standard renovascular anatomy, but also in those who had variations in the anatomy, or who had difficult anatomy, we can say in that way. So then another idea was of doing this study was the retrieval incision. You could retrieve from the anterior subcostal or a phalansteal. Phalansteal incision would be hidden behind the clothes. So especially for the ladies, which are actually about 60% of our donors. The spousal donation is the most common donation. So the scar would come under the, it would not be visible. So again, we performed a study and then we found that Ferrous steel was good, and it was less painful also because we were not cutting the muscle in this area, we were just splitting the muscle. So as compared to lumbar incision where this kidney is being pulled out, the Ferrous steel incision is hidden and is less painful also in the, so this is again another paper which was published. So then from the donor nephrectomy, I'll switch over to the radical nephrectomy. And again, the issue at that point in time was that in radical nephrectomy, sometimes we have very large tumors. So how to deal with them laparoscopically? Can they be safely removed? That was the issue. And then slowly with some experience we started, and then we found that yes, it is safe. And we were initially taking only the smaller tumors for laparoscopic retrieval. Later on, we went ahead with the larger tumors. So when the larger tumors came, again, there was, a learning curve and lot of points which we learned during that time, that how to tackle very, very large tumors. Should this be combined with the retroperitoneoscopic technique as well? So one is, all we know is the transperitoneal, which is the standard conventional laparoscopy. And the other thing is to go from the back where you can tackle the kidney retroperitoneoscopically. So in some of the large tumors, even the combined technique was used, where the renal artery was clipped from the back and then the entire specimen or the kidney was mobilized transperitoneally and retrieved. So these are some of the things. And these are the kind of large tumors, as you can see on this side, a huge, big tumor here, very large. And then how to take, and then we realized that in this category, which are the tumors who should undergo preoperative embolization to make it safe? Because otherwise, sometimes, especially on the right side, urologists, some who are here, Bhava is there and Apul is there, they know how treacherous the renal vein can be when it bleeds. From the IVC, once it starts bleeding, that's a nightmare for any urologist. So how to make it safe laparoscopically, that is where we worked in that area. And because we found there was a very high conversion rate from laparoscopy to open when the tumors were very large. And that is where we did some of these studies, because in literature there was nothing much mentioned about this. And finally developed a imaging-based scoring system, where from the preoperative CT scan itself a surgeon can predict that how difficult this particular tumor is going to be, whether we should tackle it with a preoperative embolization or open surgery, or whether we should go for laparoscopy. So this is a classification which I developed over the years, looking at the renal artery vein. This is all CT-based classification, parasitic vessels, the diameter of the tumor versus the diameter of the abdominal wall, and the location of the mass. These are those pictures with some of the diagram, where I've tried to show that what are the difficulties which you get when you do a very large right-sided tumor specifically, because once you get into trouble and it starts bleeding, then it's a real nightmare. So again, here you see a huge large tumor with lot of parasitic vessels, and these are the other few diagrams with a lot of lymph nodes also in that area, making your life difficult during the laparoscopy. So with the radiology department help, finally we came to this, and we scored it out of 20 to make it whether, so if they score about 7 to 10, then we put them into middle level of difficulty, and those who had a smaller score, so one should go straight away with the laparoscopic retrieval. When the scores were higher, then you need to do a preoperative embolization and then do laparoscopy, and preferably a very experienced surgeon should be taking those large tumors. So those are the things which, this is the paper which was finally published and is undergoing external validation. So the important messages, as I said, was the judicious use of preoperative embolization. If you find on a CT scan that the tumor is very difficult. Then jumping over to the field of reconstructive urology and laparoscopy, pyeloplasty, and then if there were stones in the kidney, they were all slowly, we all started removing them. And these are some of the papers where the concomitant stones as well as pyeloplasty, everything was done. And then going over to the simple nephrectomy, which is not always very simple. This is what I am going to say, that these are the cases of xanthogranulomatous pyelonephritis, where if you get stuck, this is another nightmare for the surgeons. So how to preoperatively, because in laparoscopy there is no haptic feedback. You don't have, you cannot, look at the what kind of tissues are there. So again, CT-based classification, which I will show you here, and it's important to suspect that this patient who has probably you are doing, say, nephrectomy for a stone disease, but you have to suspect in the preoperative, during preoperative timing only, that whether how difficult this nephrectomy is going to be, because a xanthogranulomatous pyelonephritis, if it happens because of a long-standing stone disease or in diabetics, then it will be like a stone, a fibrotic kidney stuck to all the structures around. There could be duodenal injury, vessel injuries. So all these things you can predict actually on a preoperative CT. This was a study which we did, and we found matched the CT findings with the operative findings, and grade 1, grade 2, and if there were grade 3 changes, so these were the cases where we suggested that one should go for open rather than trying laparoscopy and getting into issues. So those were the other area where we, with our experience and work, we could make it safe. So the whole idea was, as we were struggling, as we had our share of initial complications, how to avoid them? What should the other surgeons or we ourselves do to make the complications least? So those were the ideas of these studies. Then so these were some of the intraoperative predictors. Preoperative, as I said, with the CT scan. And if there is a very difficult grade 3 xanthogranulomatous pyelonephritis, that even during open nephrectomy, people have done damage to the, say on the right side, the duodenum, IVC, colon. So all this is described in literature. So what is safe? Safe is a subcapsular approach, where you should not be touching any of these structures around. Just go open, give a small incision on the capsule of the kidney, go around. The vessels are atretic, vein, artery. Over the years of this non-functioning kidney, they become atretic, and it is very easy to take the kidney out. So safest method. Then finally, at the end of the talk, I would say that I also developed this retroperitoneoscopic approach, because as compared to transperitoneal approach, this approach has the landmarks are not as clear. The space is very limited, because ultimately in retroperitoneum it is a potential space. So with a balloon and all, you make a space, and then you go around, do whatever nephrectomy, pyelolithotomy, or ureterolithotomy, cyst excision, whatever upper tract surgery you do. So over the years, we developed this, and then this is one of the papers which in the Journal of Minimally Invasive Surgery, about 400 cases of retroperitoneoscopy. And now actually with the robot coming in, this retroperitoneoscopic approach, which has not been very popular, the popular approach is transperitoneal only, because there is ample space, lot of known landmarks, and the learning curve is also very easy. So with retroperitoneoscopic approach, which was actually, if you see, kidneys were already historically approached retroperitoneoscopically. Nobody was opening the abdomen or dealing with the liver, bowel and all, to reach the kidney. So now, so judicious use of this approach is also important. And there were issues with this approach with the laparoscopy because of these limitations with the instruments and all. With the robotic approach coming up, we know suturing has become very easy. So when in my last 4 years in SGPGI, I did the robotic retroperitoneoscopic partial nephrectomies, pyeloplasties. So now this is actually coming up. Now, if you see the literature also from the US and UK, the surgeons are going more wherever they can do a retroperitoneoscopic approach. They would not like to go transperitoneal. Because as I said, you don't need to look at the other organs or mobilize them, and at the same time, the element of ileus is also very less. So actually the same evening or maybe next morning, the patient can go home if he is otherwise fine. So these are the advantages of the retroperitoneoscopic approach. So these are some of the things I've been more for this. Thank you very much for.
Thank you, sir. Professor Anish Srivastava, sir. During all your presentation, I was observing that everybody in the hall was enjoying your lecture. It is honor for this occasion to have the speakers like you, and the institutions are recognized by by you in which you worked. As a tradition, these orations and lectures have two purposes. Number one, the range of surgery, the range of the technology, dexterity, alternatives you have, and lifetime experience, along with your philosophical expressions the audience get. Here I want to take advantage of this occasion to welcome in the crowd, in the audience, Professor Prabal Niyogi. He is from Allahabad, Prayagraj, and he is the sitting President of Association of Surgeons of India, UP chapter, and elected President of Association of Surgeons of India, which is a matter of pride for UP, Uttar Pradesh. 3 cheers to Professor Niyogi. I must also tell that I am from same alma mater, Eminency, Allahabad, from where he belongs. The second is that the two teachers are the teachers, and my teachers, Professor Ramakant and Dr. Maurya, are sitting here. Along with the senior person, Dr. S.K. Mishra. S.K. Mishra के बारे में, sir, I want to take this platform on your lecture. Dr. S.K. Mishra साहब ने टेलीमेडिसिन यहाँ पे शुरू किया. गवर्नमेंट नेशनल लेवल पे, इवन नेशनल लेवल पे मोदी साहब ने रियलाइज कर लिया टेलीमेडिसिन इज द आंसर. So again, I want to smile at past, president, present, and future of President of Association of Surgeons of India from the Department of KGMU is also sitting here, somebody in the future. Thank you.
Thank you.
I'll also like to thank you, sir, for taking us through the journey of how things evolved. Let me add, SGPGI is a pioneer of introducing laparoscopic urological surgery in the country, and sir has nicely taken us through the entire journey. As he rightly said in the beginning, what we are seeing today is what we have achieved over these years. But the journey started from scratch. World over, the first laparoscopic nephrectomy was described only 1 or 2 years before SGPGI started. All the NEET toppers, all the top 5 toppers typically join SGPGI because it is a leader in teaching laparoscopic and upper tract endourology to the students. And a big credit goes to Professor Anish Srivastava actually for establishing laparoscopic urology in SGPGI. Thank you, sir. It was a big honor. All of us that you spoke the Professor T.C. Goel guest lecture. Thank you, sir.
Thank you, sir. I request the chairpersons to please stay back on the dais. Next we commence with, so please stay back. Next we commence with the prestigious Professor S.C. Mishra oration. I would request the chairpersons to kindly introduce our next speaker.
S.C. Mishra oration of 2022. It was not delivered last year due to some unavailability of the speaker due to health issues.
Thank you. We are honored to invite Professor S.D. Mishra, sir. S.D. Maurya, Professor from Agra, to the dais for his presentation. Welcome, sir. Professor S.D. Maurya has to speak on a management of CVD stones in the minimally invasive era. He has experience of 36 years in the field of surgery. Born in Jaunpur, did his MBBS and MS from GSUM Medical College, Kanpur in the year 1974. Appointed as lecturer in surgery in SN Medical College, Agra in 1975. Dr. Maurya practices at Sachkhand Hospital in Sikandra, Agra. He is run under dynamic leadership of him. His aim was to serve the poor and suffering ailing humanity with the philosophy of Gita, Nishkam Seva. Dr. S.D. Maurya has started seeing all the patients free of cost as his nursing home. He used to operate all the patients at bare minimum cost only to meet hospital expenses on the basis of no profit, no loss. This system is still prevailing for all the patients even today. Dr. Maurya is one of the pioneers of laparoscopic surgery in India. He started doing laparoscopic surgery in 1995 and currently he performs more than 40 procedures by laparoscopy regularly at Sachkhand Hospital. He does a variety of surgical procedures, full range, including intra-abdominal, retroperitoneal, extraperitoneal, gynecological, urological, oncology, and solid organ surgery by laparoscopy, as well as open when required. Dr. Maurya is an eminent national and international faculty for laparoscopic surgery, as we know. He is regularly and frequently invited as an eminent faculty to conduct workshops where he demonstrates and teaches various laparoscopic procedures. There is no state in India where he has not demonstrated his laparoscopic skills and part his knowledge. He has been invited as international faculty to China, Germany, Singapore, Greece, and other countries as well. Dr. Verma firmly believes in policy of providing best health care to all from rich to poor, and he is a good surgical teacher. With these words, I invite him to please present his lecture.
मैं आप सभी लोगों को बहुत बहुत नमन करता हूँ. आपके अंदर बैठे विद्यमान परमात्मा को बहुत प्रणाम करता हूँ. Thank you, chairpersons. Whatever you have spoken, that is for this mortal body, not for me. I am not that. Anyhow, thank you very much. I thank you all, especially Professor Arun Sahab, who gave this opportunity to share with you little knowledge in this institution of great eminence, which has produced many, many laureates and stalwarts in the field of medicine. One of them has been Professor S.C. Mishra, who worked as Professor of Surgery from 1939 to 1970 for more than about 31 years. I think that used to be the longest period of professor in that era, but now not nowadays. Professor Mishra, later on he became emeritus professor. He established experimental surgery in my institution from where I come from, Agra. Also he did it in KGMC here. And I know that you people know better than me what Professor Mishra did for this institution. When we see this institution where the department surgery has progressed and we have got almost all advanced surgery being done over here, having all specialty and subspecialty, so that credit goes to him. Today, we are gathered here to pay tribute to Professor S.C. Mishra. My ये गड़बड़ हो रहा है ये वीडियो चल रही है ना हाँ ये चल रही थोड़ा सा इसमें मैं रिक्वेस्ट यू ऑल to just please stand up at your place to pay tribute to such Guru. Kindly recite this verse with me. Guru Brahma, Guru Vishnu, Guru Dev Maheshwara, Guru Sachar Param Brahm Tasmai Shri Guruvai Namah. So I am taking you to ancient India, Indian philosophy, where Guru was worshipped like God. The glory of Guru, please take your seat. Thank you so much for standing. The glory of Guru, next. Glory of Guru cannot be expressed in the words because words has got limitation, while as the glory has got no limit. You can appreciate this with the feeling which was expressed by highly enlightened Saint Kabir Das Ji, who wrote this verse, सब धरती कागज करूं लेखन करूं बन राय सात समुद्र मस करूं गुरगुण लिखा न जाए मीन्स पूरी पृथ्वी का कागज बनाए ये पूरी वन संपदा का लेखनी और सात समुद्र में जितना पानी उसका इंक बनाए रोशनी फिर भी गुरु गुण लिखा नहीं जा सकता एक्चुअली व्हाट ही वांट्स टू कन्वे टू अस that Guru is synonym of God. हम परमात्मा ईश्वर गुरु all are same. वो आपके अंदर भी वही बैठे हैं लेकिन हम उसको जानते नहीं हैं क्योंकि हम इतने enlightened नहीं हैं. So thank you. Now I quote this teaching of Bible. Give the best you have, best shall come back to you. The philosophy of this is that whenever you give something to someone, actually you are not giving. You receive it back because universe does not keep anything of anybody, not even sound. If you just shout anything over a mountain or in the well, you will find echo back. That is the philosophy which was taught by Christ. I am sharing it here. And you will find its implication when we shall discuss later on. Before I start my talk, I just say that I have come here to learn, not to teach. And in this talk, I have made at several places, I have expressed my own opinion, and that is not binding to anybody. So today's topic, which has been dedicated to the teacher, Professor S.C. Mishra, is management of bile duct stone in minimally invasive era. We know that investigation means evaluation and treatment of bile duct stone has changed a lot over the years because of emergence of newer imaging technique, especially MRCP, endoscopic ultrasound, laparoscopic ultrasound. So they have changed a lot. And at the same time, minimally invasive technique in form of endoscopic retrieval and at the same, and also minimally invasive surgery. Even then, today we do not have consensus on ideal treatment of concurrent gallbladder stone with CVD stone because both procedures which are presently practiced by and large, either you can have option of two-stage procedure, that is the
ERCP, I do not say ERCP because ERCP is only therapeutic, is only diagnostic procedure. So it is misnomer. I will say endoscopic sphincterotomy because that is the therapeutic procedure. So I will say ES followed by lab chole, or it is two-stage procedure, or we can have one-stage procedure, that is lab chole with CBD same time. Both procedures have got advantage and disadvantage over each other. At the same time, these technical issues which we will discuss a little later, we have got consideration of clinical profile of the patient, which is very important when we choose appropriate procedure for their scenario. That is the age of the patient, means elderly patient coming with comorbid condition, the fitness of the patient, presence of jaundice, cholangitis, pancreatitis, and also anatomy of the bile duct and size of stone, number of stone also forces to choose options. We are not going to teach the incidence. We all know the incidence of CVD stone, but what I want to mention over here, that sometimes patient comes to you, younger patient comes to you with incidental gallbladder stone, incidentally. Ultrasound was done for something else, you find there is gallstone. So there are two schools of thought. Should you advise lab chole to such patient? Some will say it should not be done unless patient becomes symptomatic. But what happens if you allow long time for younger patient to have this stone, there will be high chance for migrating stone to CBD and patient will have complication. That's why you will find the incidence increases as the duration of illness and with a smaller stone. If there is one big stone, is unlikely to migrate to CBD. And therefore, my submission is that if patient comes with even incidental finding, the gallstone, well, anybody can differ, but I submit that if younger patient, you can go for surgery, but elderly patient, suppose patient comes in 8th decade or 9th decade, I will never advise surgery for those patients. So that is why I have mentioned this incidence, but otherwise I'm not going to teach the like MBBS students. So we all know that these stones are secondary stone, but primary stone are also well known, and that is either because of stasis of the CVD, as may happen congenitally in case of political cyst, or also in Caroli's disease, intrahepatic ductal stones are formed, and these primary stones can also be due to infection, which may be bacterial, as we find in case of cholangitis or in Coulon's sinensis, or also it can be a genetic problem, as we find in case of hemolytic disease. Now, investigation, by and large, we all know that cheapest, simplest, easily available everywhere is ultrasound. Of course, it's operator dependent, but its accuracy rate is up to 70%. If your ultrasonographer is good, you can detect it. Suppose you fail to detect it, then next better is MRCP, which delineates whole bile duct anatomy, and accuracy rate, sensitivity rate is about 98%. Now, newer techniques, now we have got better technique. This one I want. Now we have got better technique for investigation, which has dispensed the intraoperative colonography, that is endoscopic ultrasound or laparoscopic ultrasound, which delineates whole anatomy with accuracy rate of 100%. You can know the intraliminal pathology, intramural pathology, as well as extramural pathology. Now, treatment options. I have mentioned dissolution therapy, which is not done nowadays. So I have written to condemn, not to recommend. Then lithotripsy, ESWL, is not used nowadays, but some time back it was used to break the stone, which later on were removed by ES. And then we have got, now we have got better lithotripsy procedure like mechanical, pneumatic, we have got laser, which is available almost in all good places. This is small video of laser, which you can see. With the laser, you can break all stone. It becomes just like dust, and you can take it out. This is also, you are pressing the urology, same thing over here. Now, the other treatment option is the ERCP. I have mentioned ERCP. I said it is a misnomer. Actually, the term is endoscopic spectrotomy and retrieval of stone. It can be preoperative, intraoperative, or postoperative, with or without lithotripsy. And the next is the laparoscopy. We can do it by transcystic or transcondylocal, again with or without lithotripsy. Then we have got, rarely we need it, that is percutaneous transhepatic approach for dealing with intrahepatic ductal stone where access is not possible through bile duct. And then lastly, it is open surgery I mentioned, that is the parent. When everything fails, we go for open surgery. Now, selection criteria, how to select the procedure. When we think of this, we have got three important considerations. One is the patient, other is the procedure, and third is the treating clinician. Most important in this universe, if I ask this question to us, is the life of the patient. Means everybody's life is invaluable. So why I mention this? That whenever you choose procedure, you must see that procedure must ensure highest chance of success with zero risk to patient life and with minimal or no complication. And whenever something happens wrong in midst of the procedure, you can change, convert, or modify, or even can abandon. This is the wisdom of the treating surgeon, not the complication. This will serve the both patient's life as well as it will protect you from consumer forum. Now coming to procedure, we know that every procedure has got advantage and disadvantage over each other. Some may be more, some may be less. At the same time, the procedure has got overlap. We will discuss this scenario that there are overlaps in procedure. And thirdly, also we will find that procedures are complementary to each other. So there should not be ego factor which operates, that is the treating clinician. What happens, endoscopist or surgeon, whosoever, they are inclined to opt the procedure to which they are most adept, though that procedure may not be safer and may not ensure 100% success to the patient. So what should be done in that scenario? What should be done? This is a dilemma, how to solve this. What I suggest and what I feel and practice, that if treating clinician puts himself in that scenario, lying on operation table, think that what is best for him, that best should be offered to the patient. That because patient is none other than your own self in some other name and form of the body. That is the ancient philosophy of our Indian, that what we call as Advait, one without the other. If you cultivate this philosophy, that patient is none other than your own self, then what you need, that should be offered to the patient. And if you practice this, I'm sure your decision will never be wrong. Now, I'm just citing some example. Of course, there is no guideline published today, but these are recommendations based on evidence. What should be done where? Patient, suppose elderly patient, 8th or 9th decade coming to you with CBD stone or gallbladder stone with CBD stone, because these patients are having comorbid condition, their endoscopic spectrotomy is safer because these patients are not fit for surgery. So that is the treatment of choice. Now, second scenario where patient has got jaundice, cholangitis, and pancreatitis with sepsis. There again, ES is better option because these patients are not fit for major surgery by laparoscopy. Even if you do ES, just put a stent, you are not able to retrieve the stone, that will be sufficient to overcome the crisis, and then we gain the time. Later on, you can go ahead for removal of stone by anything. So that is how we can salvage that crisis. Then post-corticostomy condition, again, treatment best option is endoscopic spirotomy. But we can also, we have been doing, I will show you some video, that even we do redo this CBD exploration after 4 or 5 years, patient coming with big stone. If ERC fails, you can go for laparoscopy as well. Anyhow, the first choice is endoscopic spirotomy. Now, fifth condition, where CBD is less than 10 mm and patient has got smaller stones in the CBD. Best option again is go for endoscopic spirotomy. Now, next scenario is CBD is dilated more than 10 mm, stones are between 1 to 1 centimeter up to 2 centimeter. This is the situation where you can do either a procedure with same success rate. You can do ES followed by lab chole or lab chole with CBD. Both will have equal result. But laparoscopic will have advantage over the ES because it is sphincter conserving surgery, number one. Number two, hospital stay is less, at the same time it's cost effective. And moreover, lab CBD has got advantage over the ES because you can clear right from intrahepatic ductal stone to lower down under vision. That is advantage that you are doing. We are removing all stone under vision, and then you confirm clearance by repeated orodicoscopy. While as ES, up to cannulation, it is under vision. After that, you are doing surgery under image, that is cholangiography. So you are not doing under vision, therefore laparoscopy is superior to that in that situation. Now, another situation where chances of ES failure is very imminent, because suppose stones are very big, more than 2.5 centimeters, impacted, whole of the CBD is loaded. So these are the cases where laparoscopy is better than ES because chances of ES failure is very imminent. And then residual stones, of course, again choices of residual stone is the endoscopy procedure. Now, I am showing some video. You can see this is ERCP, this stone impacted. खड़े रोक में आ रही हैं, ये चलाओ, वीडियो चलाओ. This is the stone impacted at the lower end of the CBD. You can see a stone there, and just see it is removed. So this is a very good technique for this. Impacted stone at the lower end, CBD single stone, you can remove it. This and next. Then ES, if facility is available, can be associated with in the intraoperative, means lab chole. You attempt lab chole first, open the cystic duct, cannulate it, and pass a guide wire through cystic duct into CBD to guide the endoscopic surgeon at the ampulla. Then he can cannulate under the guidance of the guide wire. This has got advantage because it becomes a single stage procedure, and at the same time you find hospital stay is less cost effective. At the same time, it has been found that if you combine this called Randau procedure, this, if you combine this, then it has been found that even complications are less as compared to ES done alone. Then we have got post-cholecystectomy ES. That is again good, very good, but there is apprehension that if ES fails, then you may require third procedure later on. Nowadays, flexible cholangioscope is available. You can put cholangioscope through the endoscope and you can do undervision. Of course, it is a fragile and a costly, but it is available nowadays. Now, limitation of endoscopic sphincterotomy. First is the difficult access to the CBD. That is in case of perimpulmonary diverticulum of duodenum, if CBD is sigmoid shapes, and post-operative condition, discuss it later, in those situations, ES has got limitation. And all these limitations are very well manageable by laparoscopy. That is why I say that procedures are complementary to each other. Failure of one or limitation of one is manageable by other. To complication, though no procedure is free from complication. Either you are doing ES, here complication is because of sphincter damage. That is, the commonest complication is the pancreatitis. And if pancreatitis sometimes becomes very serious with sepsis, then you have got mortality from 0.5 to 1%. Otherwise, duodenal bleed, duodenal perforation, and recurrent cholangitis are the common. Late complications are papillary stenosis, recurrent gallbladder stones, and also it has been reported in literature that these patients where there is recurrent cholangitis, they are more prone for developing cholangiocarcinoma. Then laparoscopic CVT exploration, we have got transcystic approach and transcortical approach. Transcystic approach has got limitation because you cannot remove bigger stone through transcystic approach. That's why in the Indian scenario, we do not prefer it because it has maximum size of stone which you can retrieve through cystic duct is about 6 millimeter. And also it has got limitation because if you dilate it, there is chances of it can avulsion. The proximal CBD stone cannot be removed by transcystic approach, and also anatomy of cystic duct sometimes lower insertion, sometimes anterior insertion, sometimes very high insertion. So there are problems, and we are using flexible cholecystoscope, which is fragile and costly. So most of the time at our center, I have not taught about the transcystic approach. I always prefer transcortical approach because patients coming to us are having big stones. I will show you. This is the only thing that I have changed is that we have shifted epigastric port little lateral towards more right side so that it comes in the line of CBD, and the second working port has been shifted more medially so that when we have to put scope, cholecystoscope, actually we are using the rigid cholecystoscope, so we want that CBD access should be in our field. So this is the patient which has come to us with failed ERCP, and whole of the CBD was studded with stone. You will surprise that there were intrahepatic ductal stone, 14 in number, which we have removed successfully. So I will show you this good video. See, whole of the CBD full of the stone. We just incise the CBD, and whatever stones are seen, we go on removing. This was you see, the stent was removed. We are going to remove all the stones which are easily seen, and go on irrigating and see the stones, they are seen, go on removing it. We put retrieval bag in advance, we put gauze piece in advance. So just see that we are removing all the stone. We will show you. We are proceeding to remove the intrahepatic ductal stones. See, this is intrahepatic ductal stone which are removing with tri-pronged forceps under vision, and I will show you that these stones also that was at the lower end which was retrieved. Now we shall go towards the upper end. That is, I will show you. I will take little more time, but I will try to complete within time, okay? So, see this important video I am showing you, otherwise I could have skipped over, because intrahepatic ductal stones are very difficult to remove. In this video I have shown that if you go on irrigating, many stones will come by itself. Just see, the stones are coming. Just see, the stones are coming out. We have removed all, this is, I am taking a little more time in this, otherwise in other videos I will not take that much time. We can skip over, but just see the intrahepatic ductal stones coming by irrigation. That's very important to observe. Those who are venturing laparoscopy CBD exploration, for them it is very important to watch. Okay, I will skip over. This is another where we have broken the, we have used mechanical lithotripter to break the stone lower down. Just watch this video. In this, what happened, we have used mechanical, the biprong forceps to break the stone lower down. Can you show that? नहीं चल पा रहा है. अच्छा आगे चल. चल कोई बात. Skip. Next. क्या हो गया? ये तो वही आ रहा. आगे बढ़ जाओ. दूसरा नेक्स्ट स्लाइड. नेक्स्ट. इसे दिखाओ. This is what I have shown you, that is the cornerstone made actually nephroscope we are using as corticoscope. This is a rigid one. It has got good working channel, so we can remove. You see, this is another video where we have removed intrahepatic ductal stones through the same. चलो आगे बढ़ो. Next one. This one. This is the CBD stone where 28 stones were removed. Whole of the CBD was studded with stone. Just next one. उससे दिखा दो. हाँ. आगे नहीं ये नहीं हुआ. This one. This is again another example of failed ERCP. We are getting quite a good number of cases where failed ERCP are coming to us. So you will see this. Sometimes just if you remove the stent, it helps. The stone comes from lower down to in the, you can see the stone has come. Just see, the stone has come. Just by removing the stent, you can find the stone has come, and you remove it. We confirm by coloscope and confirm, and then do primary suturing. Next. You can see again an example of very large stone, which I am showing. Very large stone which you can do with laparoscopy better than ES. Quite big stone. ऐसे दिखाई नहीं हो पाएगा. हाँ ये दिखाओ. Very large stone. हाँ ठीक. Okay. हाँ. Just see the very big stone which was we are removing. Just see the size of stone. So some tips I want to give this one. If you give buscopan injection just beginning of the surgery, when you are going, then it dilates the sphincter and you can push some stones down, and using Fogarty's catheter or stone basket can help you. And intraoperative, if you find stone big, you can use lithotripter. By now we have done more than 2,000 cases. About it's little later. Now we have crossed about 2,500 cases. We have done by now. We had our share of complications and conversion. We have converted into 22 cases where there were dense adhesion because of bleeding in 8 cases, CVD injury in 3 cases. In post-ostomy cases, ERCP anatomy could not be defined, delineated in 39 cases. Next. We have got our own share of complications. As I say, neither procedure is free of complication, but we should make all attempt to minimize the complication, and when we detect it, we must treat it. And conversion or abandoning procedure, I consider, is not a complication. This is the wisdom of the surgeon to convert. Now, management of difficult stone. Management of difficult stone. How to manage difficult stones? You have to break the stone by using any sort of lithotripsy. Either ESWL you can use, mechanical, pneumatic, or laser. That I have mentioned that the only way, both laparoscopic as well as ES, they are doing it. And when everything fails, we go to parent. This sketch photo of my father and mother. I have shown you that never forget your parents. Whenever you are in crisis, we go to the parent, means crisis here for open surgery. When everything fails, this open surgery has to be done. That is in a recurrence with failed ES. Either you can surgical method that you can do either by laparoscopy or by open cholecystectomy with drainage procedure. Actually, whenever CVD is dilated more than 2.5 centimeter, some sort of drainage procedure is required. Otherwise, patient will have chances of recurrent stone. And you have got two options. Either you can do cholecystectomy. Of course, we do cholecystectomy by laparoscopy. It is easy anatomically, but it has got complication because of some syndrome and also cholangitis. Cholangitis means patient will have infection, patient will have pain, and patient can have recurrent stone. And over cholecystectomy, either Roux-en-Y or hepatocholecystectomy is better option. And when you make Roux-en-Y procedure, then we can bring an access loop under the skin. Suppose patient requires sometime anything, then we can reach again to the CBD through that access loop. Prevention of recurrent stone. Can I take a few minutes little? Can? Prevention of recurrent stone. We know that recurrent stone is a problem. For that, we can do prophylactic ERCP every year. In those cases, it has been found that if you do repeated ERCP, you can prevent the recurrence. And people do advise ursodeoxycholic acid, but it has got no role because these stones are refractory, because these stones are most of the time pigment stones which cannot be dissolved by this. And most important factor for recurrence is the dilated CBD. If you do drainage procedure, as I mentioned, cholecystectomy or hepatocholecystectomy, that is probably better option. Consensus based on review of literature, I will not take you a lot of time, but just mentioning that no significant difference in the CBD stone clearance rate over. So consensus, just I am summarizing that if you go to the literature, they will find endoscopic ES and laparoscopy both have got almost similar success rate, but complication in ES is more because of sphincter damage, and if you compare the cost, duration of hospital stay, you will find hospital stay is less in the single step procedure, cost is less in the single step procedure, morbidity is less in the single step procedure, except in case of laparoscopic explosion, we have complication because we enter the pneumoperitoneum. That's complication of GE and pneumoperitoneum will be there, otherwise it is safer. Now I'm just concluding that when more than one option is available for treating one condition, it reflects that neither of procedure is applicable in every situation. So this is dilemma what we should, I have mentioned earlier, that treating surgeon or treating endoscopist should select the procedure which ensures the highest chance of success with no risk to the patient life. As I mentioned earlier, that put yourself in that position and consider what is best for you, that best should be offered to that. That is my philosophy to teach, and that's I'm practicing. And next, just take home message. I conclude this talk with the emphasis that life is supreme, and therefore every effort should be that no risk to the patient. And patient procedures are not meant for the patient, but sorry, the patient is not meant for the procedure. Patient is not an experimental element. Procedures are meant for the patient. Whenever there is a need, you can modify, change. Now, last, I want to conclude that normally when we are in trouble, we remember God, we pray God for His grace. But I submit that if you start praying for everything, you submit to God for everything, for every activity from wake up to sleep, from sleep to wake up again, everything all the time, you remember God and submit yourself and kill your eye in yourself and have no doership, you will find your life will be very smooth, you will be tension free, you will be very happy, you will be one with the God. That is what I want to submit to you all. With these words, I thank you very much. Again, आप सबके अंदर विद्यमान परमात्मा बहुत बहुत नमन करता हूँ. Thank you so much.
Thank you, sir, for your very enlightening talk on a very common, complex, and contentious topic. I call it complex because it involves 4 departments: surgery, gastroenterology, surgical gastroenterology, and interventional radiology. And I call it contentious because each of the specialists, when you talk to, will advocate the procedure of his department. But you have given a very excellent overview and a balanced overview of all these 4 departments. Thank you, sir.
Thank you, sir. I would now request Professor Vinod Jain, sir, and Professor Arshad Ahmed, sir, to kindly felicitate our chairpersons. Professor R.B. Singh, sir. I also request Professor Suresh, sir, to kindly join the dais and please felicitate our guests. Professor K.K. Singh, sir. Professor Apul Goel, sir.
Thank you, everyone. And we will now proceed to the inaugural ceremony of 111th Foundation Day of the Department of Surgery. We are not dispersing anywhere. Give us a break for just a minute and we should be preparing soon. Thank you. I request everyone to stay in the hall, please. We are going to start the inaugural ceremony very soon. So, good afternoon, everyone. And we are now proceeding to the inaugural ceremony of 111th Foundation Day of the Department of Surgery. To start the function, may I now request on the stage the chief guest of the function, Dr. Prabal Neogi sir, to kindly come and grace the dais. I also request Professor A.K. Tripathi sir, the presiding officer to Honorable Vice Chancellor, and the guest of honor for today to kindly grace the dais. And I request the girls to extend floral welcome to the dignitaries. May I also request the Chief Medical Superintendent, Professor S.N. Shankwar sir, to kindly come on the stage. We welcome you, sir. May I now request the Head of Department, Professor Abhinav Arun Sonkar sir, to kindly grace the dais, and Professor K.K. Singh sir to kindly come forward. Lastly, I would request the Organizing Secretary, Dr. Ajay Pal, to kindly come. Thank you, dignitaries. To evoke the blessings of divine, I request the dignitaries to please come forward for the lighting of the lamp. A heartfelt thanks to all of you. May I now request on the podium Professor K.K. Singh sir to welcome the dignitaries, faculty and delegates.
Good afternoon, everyone. It is my pleasure to welcome you all at the 111th Foundation Day of the prestigious Department of Surgery of KGMU. I warmly welcome our distinguished guests, especially Dr. Probal Neogi, Professor Shankwar, Professor A.K. Tripathi, my head of department, my teachers, my seniors, colleagues, and students. I am grateful on the behalf of the department for the speakers and chairpersons who have taken off so precious time from their busy schedule, and so that we could have such a wonderful interactive 4 orations. I am thankful to all of them. Today, we are celebrating the 111th Foundation Day of our department. We honor our foundation fathers of the department as we reflect on the commitment, resilience, and dedication they displayed to see their vision of a vibrant surgery department, and that became a reality. Every year, when this day is celebrated, it is time to reflect on the beginning, remember the journey since inception, and the changes that have paved the way for a successful department of surgery. As we know, this is one of the oldest departments of surgery in India and undoubtedly the most prestigious department. You cannot name a single post which could have been held by a surgeon and which was not held by our alumni. May it be the surgeon of Association of Surgeons of India, President of Medical Council of India, Vice Chancellor, you may name any post which a surgeon could have held, has been held by our alumni. So on this day, we have to remember that this is the department of such a high prestige in which we are working. We have to remember the journey through which this department has not evolved or developed in a day or two. It had a very strong foundation which was laid down. And for any successful department, family or any unit, the first and foremost thing is the strong foundation. And I am very happy that now it is proved beyond doubt that the foundation of this department is one of the strongest foundations all over India. So we have to remember the journey through which it passed. So many luminary teachers. See, most of the department give you graduates, postgraduates, maybe super specialists also. But this department of surgery has given birth to 10 super specialty departments. And each time our department was divided, and from here the faculty went and started that department. But every time this department has become more vibrant and strong even after the 10 divisions. And today it has a faculty of nearly 20. Still we have 8 units. Still we can divide and make few more departments. So on the foundation day, as a teacher, I would request all my students and colleagues to take a pledge that we will keep this journey going in this and in even a better way. Thank you.
Thank you, sir. May I now request our dignitaries to kindly release the newsletter of annual report of the Department of Surgery. I now request Professor Abhinav Arun Sonkar sir to kindly come forward to read the annual report of the department.
A very good afternoon to all of you, and my best wishes on the occasion of Mahashivratri. And I know a lot of people have come from home. Someone must have been fasting, and we realized it later that today is Shivratri, and when the Shivratri is there, kind of feasting and frolicking, you have to put a deck on it. My teacher, Professor Ramakant, understands it. Less I say and more he understands. Honorable Chief Guest, sir, Professor Prabal Niyogi, Dada, आपका भीषण स्वागत and धन्यवाद for coming. My teacher, Professor A.K. Tripathi, sir, Dean, Academics, and officiating Vice Chancellor, who shall be presiding over the function. Professor S.N. Sankwar, Chief Medical Superintendent and Guest of Honor. Professor K.K. Singh, Professor Ajay Kumar Pal, who is the Organizing Secretary. And people say the workhorse behind the whole thing. I would say he's the bull behind the whole thing. Difficult to, nudge him from the inertia, but once he's in motion, difficult to stop him either. We talked about, Dr. K.K. Singh talks about the department, and this was the one of the oldest departments of in the King George's Medical University. Illustrious things to have. Governor Dalbu Selvi was the first head. He was an Indian Medical Services officer, and he worked at many places, and has breathed his last in Lucknow only, and he is buried here in the military cantonment. Lot of emotion is attached with the building. In 1955, this building was inaugurated by the then Chief Minister Shri Chand Bhanu Gupji, and that is why we celebrate this Department of Surgery Foundation Day. This could be gauged from the fact that Professor S.C. Mishra, after whose name the orations are there, he was thoroughly trained in UK, and he planned that the surgeon's office, operation theatre, pre-operative room, post-operative room, project ward, research ward, this all should be under one roof, and that is why this new surgical block came into being. Generally speaking, it is still the same. We all still want to plan the whole thing. Even after 65, 70 years, we want this to happen. Our glorious history, you see, Professor Colonel W. Selby, Professor S.N. Mathur was the onco surgeon. We have an oration named after him. Professor S.C. Mishra, we have oration named after him. Professor R.V. Singh is father of Professor G.K. Singh, who is head of orthopedics, director AIIMS Patna. He himself is Padam Shri and himself was Vice Chancellor of the Lucknow University. And during his time, he would do orthopedic surgery and other surgeries because general surgery gave birth to dental, general surgery gave birth to ENT, ophthalmic, other branches of surgery. Professor Charan started cardiac surgery. Professor Ramakant has worked with him, and he was a good cardiac and thoracic surgeon. And I'm talking about 70s, when people even only think of imagination. People could only imagine that these are the branches of surgery where these kind of surgery would be taking place. Professor P.C. Dubey was triple FRCS. Professor Sahi, these are the living God. He is sitting here, and he is otherwise good, but little infirm to travel and walk, come for longer durations. Probal's father himself was a batchmate of Professor R.P. Sahi. Professor N.C. Mishra started onco surgery. Professor K.N. Sinha was a cardiac surgeon, and he would do open heart surgery, first surgeon to do in the North India. Professor K.D. Verma, you must have heard him in Professor S.K. Mishra's presentation that he was the person who started endocrine surgery, and he got government to sanction endocrine surgery unit, and he was in charge of the endocrine surgery unit. And probably he was the first person in whole of the North India to start nuclear scan. Probably Delhi, one of two places, Mumbai, it must have had this facility, otherwise he was the first person. Professor Ramakant was the head of the Department of Surgery, and he was president of ASI. Professor Jaiswal was once again Hewitt medalist. And Professor K.M. Singh was part of the Department of Surgery, and he went on to create Department of Urology. He was first principal, and first Vice Chancellor. Professor Ravi Kant, Professor Sandeep Kumar, Professor T.C. Goel, these are living legends. Professor T.C. Goel, ईशो को देखने की जरूरत ही नहीं, आप इन्हीं लोगों को देख लें, जीवन धन्य हो जाएगा। इनका आशीर्वाद है सर, ये हिंदी में किताब लिखते हैं, हिंदी में पढ़ाते हैं, और लोग आज न्यू एजुकेशन पॉलिसी की बात करते हैं, एंड ही हैज बीन वर्किंग ऑन इट फॉर द लास्ट 20-30 ईयर्स बैक। हिंदी में संस्कृत में श्लोक पढ़ाना सर कि ये कुचाले और कर्कश स्तब्धो ग्रामीण समागत ना पूजन देव पंचवेद धनुदी समाज, यानी 5 प्रकार के वेदों की पूजा कहीं नहीं होती है यदि वो कर्कश बोलने में, वाणी से कर्कश है, गंदे कपड़े पहने हैं, बगैर बुलाए चला जाता है और अपने अभिमान में अभिमान रहता है। ऐसे 5 अवगुणों वाले वैद्य की कहीं पूजा प्रशंसा नहीं होती है सर। ये उन्होंने हम लोग को सर जी के ड्रेसेस बुक में लिख के दिया था। एंड दिस इज व्हाट वी आर डूइंग टुडे, व्हाट ही एज अ टीचर he thought and implemented 20-30 years back. He's still alive and healthy with God's grace, and he's writing books. He is translating whole books in Hindi, and we also call him affably as the 11 belly of the East. सर ये दी पेजेंट सर्जरी, हम लोग उनके चूजे हैं सर, आज सबके जितने हमारे इनके आशीर्वाद स्वरूप हैं। हम लोग अभी छोटे छोटे हैं, पुष्पित पल्लवित हो रहे हैं। एंड बट अ लवली फैकल्टी वी हैव, एंड as diverse they appear, as diverse their surgeries are, and as diverse their guna are, and they are doing a lot of good work, sir. Department of Surgery is divided into 8 functional units because we have 250, we induct 250 MBS students every year, and it is based on the specialty of every faculty, and everybody does general surgery, but in order to satiate their, their surgical ego, they also do their own area of interest. And this way we have got 8 surgical units, functioning units. As far as the infrastructure goes, we have 4 operation theaters, but because of the Professor S.A. Mishra's planning, we have used pre-operative surgery room and another table, and we have 8 practical functioning operation theaters, 300 beds, and 20-bedded HDU. We have endoscopy, we have OPD 3 chambers, and we have teaching rooms and minor procedures. These are just a glimpse of post-operative renovated ward, consultation rooms, operation theaters. And by the, I would like to bring on the record, sir, that university administration has been kind enough over the period of years to infuse funds in the Department of Surgery. We have anesthesia workstation, anesthesia surgery workstation, table, recording system, in lights, sterile table, state of the art. So I would not say, I would say I have been to Medanta and other places, and their infrastructure doesn't match with our infrastructure. They don't have sterile table, they don't have sterile light. I mean, at some places they may be having. Department of Surgery is in competition with itself. We have been running basic surgical skills workshop, stapling workshop, wet lab, and vascular anastomosis workshop also. And if I were to take you only last 4 days, we have been having intensive lectures, videos, case presentations for the sake of postgraduates who have to appear in exams, retired surgeons of Lucknow, practicing surgeons. And this has been the best practice of Department of Surgery. Another good thing which has happened, I would like to very happily share with you, that Department NMC was kind enough to sanction 9 more residents, and we have the intake of, from this year, we have intake of 24 residents per year. Otherwise, till 50 years back, we were only having 15 residents per year. Department of Surgery has to undertake undergraduate teaching of MBBS and BDS students and MS students, and we regularly involve in them in clinical case discussion as per NMC protocol, like clinical case presentation, rotations, and other things which are required of us. You are all aware that because of the COVID, there was a dip in the, as you can see, the total number of patients that in coming to OPD and admissions and operations. But once again, it started to pick up, and we are nearly our pre-COVID levels of 53,616 patients OPD and 9,181 admissions and nearly 10,000 major and minor operations we did this year. And this is the data of histogram of upper GI and lower GI endoscopy. Now, I would like you to ponder on this operating the various procedures which are being operated upon. And I showed this once to Professor D.K. Gupta. He said, Abhinav, this procedure, the kind of procedure you do befits our institute, now the department, and we nearly do all kinds of laparoscopic procedures, general surgery, hernia, neck, thyroid, neck dissection, endoscopic thyroidectomies, endoscopic non-functioning pheochromocytomas, functioning pheochromocytomas, oral cancers, breast, and biliary strictures and whatnot. So this year, we, Department of Surgery, organized, besides Surgical Foundation Day, UPSCon 2048, chemo port workshop, breast cancer awareness workshop program, and other programs. This is the photograph. And the achievements of the faculty, I would ponder on. It will be difficult to read about a lot of achievements of the faculty. As you can see, mine achievement is minimum. And Professor K.K. Singh has attended he was the co-organizing chairman of the 48th UPSCon, and he has an international oral presentation in France and national and ASICON as well. Dr. Pahwa's presentation, so many that I would like you to read them, and I will only read that he is in the line of becoming a very renowned uro-oncologist and robotic and minimal access surgeon. Otherwise, he is a fine general surgeon, very good laparoscopic surgeon, and he has to his credit lot of things, membership, you can, as you can see that. Professor Shailendra Kumar is a cardiothoracic surgeon, and he is presently in our hospital department, and he got best poster award at European Society of Medical Oncology Singapore meeting 2022. Professor Suresh Kumar was the organizing secretary of UPSCon 20 organized in 2022, and he has attended 3 national, 1 international conference. Professor Avnish Kumar, besides other things, paper presentation, these are all our jobs, but I will only read the notable ones, and I will give time to each slide so that every faculty member, people are able to read the achievements. And he received Best Paper Award by INS at Coimbatore. He was felicitated by Bhojpuri Samaj, and he was co-organizing chairman of UPSCon 2022. Dr. Arshad Ahmed has got a hefty repertoire here, and the workable most important I would read to me is he was joint editor of Indian Journal of Colorectal Surgery, and he has completed 2 terms as vice president of the Association of Colon and Rectal Surgeons of India, and he is still the vice president of the Lucknow chapter of ASI and academic committee member of UPSI. And another feather in his cap in the department is he is mentor to National Traveling Fellowship by the Association of Colon and Rectal Surgeons of India and UPSI, and he mentors students who come and watch, who want to learn about fissuras and other treatments of rectal cavity and rectal region. Dr. Surendra Kumar has won international presentation, and he was an external examiner for mock test in general surgery organized by Delhi State Chapter of ASI. Dr. Kushwaha, Professor Kushwaha has won first prize in ASICON 2022 at Mumbai in a competitive faculty paper presentation, and an international member of the European Venous Association. Professor Parijat has been awarded with Fellowship of Minimal Access Surgery, and he has attended MRC skill course on Surgery Foundation Day 2022. Dr. Faraz Ahmed, to his contribution, has 3 original articles, and he has written 3 book chapters. And Dr. Geetakananda Singh is, besides her being an endocrine surgeon, she is also laterally grown in Brahma Kumari's Art of Living Healing, if she is around. And she has organized, with the collaboration of Department of Radiation Oncology and Gynecology in breast cancer awareness, and she continues to do so in other platforms and places. Dr. Sanjeev Kumar has been awarded this year Fellowship of American College of Surgeons and membership of National Academy of Medical Sciences. Dr. Akshay Anand has been awarded poster presentation. He presented a poster in 49th World Congress of Surgery at Vienna, Austria. He is organizing secretary at 48th Annual Congress of UP Chapter UPSI, and it received very good and rave reviews. And he also attended a certificate course in diagnostic intervention, upper GI endoscopy, Institute of Medical and Minimal Access Surgery Training in 2022. Dr. Ajay Kumar Pal, who is the organizing secretary, sharing the chair on the dais, has been the organizing secretary of UPSCon 2022. He was awarded R.L. Subhati Oration by UPSCon and 3rd best faculty paper presentation ASICON 2022. Has been my life awarded life membership of Association of Robotic and Innovative Surgeons, and his award is kind of very close to me and liked very much when he has registered a topic with Cochrane for in systematic review, lightweight versus heavyweight mesh for inguinal hernia, which has been registered in Cochrane, and you all know that it is registering a topic in Cochrane is a very difficult job. Dr. Pankaj Kumar has attended the National RSCon Robotic Surgery Conference and Hepatobiliary Masterclass in Pondicherry, and membership of Association of Robotic and Innovative Surgeons. Dr. Soumya Singh is, besides other achievements, she has attended the International Instructor Course in Care of Critical Ill Patients, fifth course of Royal College of Surgeons, and Fellowship of International College of Robotic and Surgeons, March 22, New Delhi. Dr. Manish Kumar has been the organizing secretary of UPCon 22. Besides other achievements, Dr. Pankaj Singh he was organizing secretary of last year's the Foundation Day and Surgical Education Program, and he has attended national conference. He has organized one conference. Dr. Kushagra Gaurav, once again a popular slide, but he has been awarded with the Honorable Vice Chancellor on the Teachers' Day to be the most young popular teacher award. And besides the other achievement, he was awarded the most popular young teacher award. Dr. Amit Kaning has recently joined, and he is a member of FIAGES. Our residents are not lagging behind, sir, and they have been bringing laurels to the department in ACCON and UPCON and Association of Surgeons of India meeting. Nida Shahi got third prize in national, Ankita Bajpayee is our senior resident second year. She got second prize in competitive poster session in UPCON. Nida Shahi got third prize in surgical quiz in ACCON, second prize in UPCON surgical quiz. Dr. Abhishek Rajput, third prize in national surgical quiz ACCON 2022, and second prize in state surgical quiz UPCON. Dr. Shefali Chandra got second prize in Dr. Palani Velu PG Best Poster Paper in ACCON Mumbai. Dr. Sukesh KS got competitive paper presentation in UPCON. And Dr. Priyanshu Sharoop, Dr. Sridhar Shandil, Dr. Jaideep Soni, Dr. Deepak Gupta, and Dr. Reena Rinki Meena, as you can see, have got laurels to the department on various forums of UPCON and ACCON, and have been awarded accordingly. The department was also awarded on the Foundation Day of the King George's Medical University. The emergency part of the trauma center looked after very keenly and studiously by Dr. Manish Agrawal, Associate Professor, has won the Best Optical Biomedical Waste Management for year 22 to 23. And this was awarded in the Foundation Day program by the Honorable Vice Chancellor and the Chief Guest. Department, I'm nearing completion of my slide, sir. The department has recognized MRCS Party Center. We have also recognized DNB Center. We have held approximately 5 DNB examinations for DNB general surgery. Future plans is, sir, we wish to have a new building. We are very close to an older building, close to Bhul Bhulaiya. We cannot go upward, we cannot expand laterally because it is closer to the Bhul Bhulaiya, and therefore ASI regulations don't allow us. But the Honorable Vice Chancellor, Professor Lieutenant Puri, has been kind enough to sanction this place, and the government is in very final process of allocating and committing some budget to the place. This is the photograph of our lovely Department of Surgery, who have worked hard, who work hard day and night to bring what surgery is today. And sir, these people are working very hard, sometimes not getting the due, but still we have to work, we have to do whatever our job is. And I've always end this report by quoting Robert Frost: "Put the lovely dark and deep, but I have miles to go before I sleep." Thank you, sir. Thank you, Dennis, sir.
Thank you for the very lucid presentation, sir. It's now time to honor our orators for the most wonderful knowledge and the pearls of wisdom they shared with us. To do the honors, may I request the dignitaries to kindly come forward. So we start with the Professor S.C. Mishra Oration 2022, which is for Professor S.T. Maurya, sir. Okay. Now for 2023, Professor S.C. Mishra Oration, I request on the stage Professor S.K. Mishra, sir. A hand of applause from the audience, please. Thank you. For the Professor P.C. Dubey oration, may I now invite on the stage Professor Lileshwar Kaman, sir. Thank you. And for the Professor T.C. Goel lecture, I now invite upon the stage Professor Anish Srivastav, sir. Thank you. And I request the dignitaries to please stay, because now we are going to award our residents and our staff for all the good work and efforts they put in for the success, for the work of the department. So in the residents, I would like to invite upon Dr. Sridhar Sandilya. Dr. Juhi Rajput. Dr. Priyanshi Swaroop. Dr. Srishti Rathore. Dr. Shefali Chandra. And Dr. Sukesh K.S. And in the staff, सुश्री कांति, श्रीमती ममता और श्री आशीष वर्मा, इनको भी अवार्ड मिला था, पर किसी कारण से ये हमारे बीच में नहीं आ पाए। ओटी टेक्नीशियन श्री कृष्ण कुमार सिंह। मोहम्मद जावेद, ट्रॉमा ओटी से मोहम्मद जावेद। मोहम्मद हसन, ओटी 5। ऑफिस स्टाफ से श्रीमती रेणु वर्मा। सिक अटेंडेंट श्री आनंद वर्मा, श्री पवन कनौजी और श्री प्रशांक। श्री कौशल के लिए भी अवार्ड है, पर अभी किसी कारण से वो भी नहीं आ पाए। सफाई कर्मचारी श्री वीरेंद्र एवं श्री नरेश। और गेट चौकीदार श्री सईद अहमद। विभाग आपकी कार्य प्रतिबद्धता, सक्षमता और ईमानदारी के लिए आपको सम्मान देता है और उम्मीद करता है कि आप सब और सभी कर्मचारी एक परिवार के समान मिलकर रहेंगे और विभाग को आगे बढ़ाने के लिए और भी अच्छा कार्य करेंगे। सो थैंक यू डिग्निटरीज, यू मे ऑल बी सीटेड। May I now request our guest of honor, the Chief Medical Superintendent, Professor S.N. Shankar sir, to kindly enlighten us with his words of wisdom.
Thank you very much, Dr. Geetika ji. A very good afternoon to all of you. On the occasion of the 111th Foundation Day of Department of the General Surgery, the dignitaries on the dais, Chief guest of today's function, Dr. Niyogi, Dean Sir, Dr. Tripathi Sir, Head of Department, Dr. Abhinav Sonkar, Dr. K.K. Singh Sir, Dr. Ajay Pal, my teachers in the audience, Dr. Anish Srivastava Sir, Dr. Ramakant Sir, Vinod Jain Sir, Dr. S.K. Mishra Sir, Dr. Pahwa Sir, Dr. Kaman from Chandigarh, Dr. J.D. Rawat Sir, Dr. R.B. Singh Sir, Dr. Shailendra, Dr. Arsad, Dr. Suresh, Dr. Parihar, Dr. Avinash, Dr. Apul Goyal, Dr. Kulranjan, Dr. Kusagra, and many other faculty members standing behind. I congratulate on this occasion, and we all know department surgery is progressing like anything. As Dr. K.K. Singh sir told, many departments branched from there, but the department of surgery is still growing. Really, it is still growing. And the best thing of the department is that every faculty member has chosen one super specialty or subspecialty, and they are working on that. And I am very proud to tell at this moment, Dr. Arshad got patients from every corner of the country as well as abroad, and one patient came along with the Venflon. He did not get surgery done at Delhi, he came to our KGMU. We arranged private ward, very VIP patient, and Dr. Arshad operated that. So department is heading under the leadership of Dr. Sonkar and his team toward the very height, and I extend my best wishes on this occasion. Everybody should be very helpful to each other. सभी लोग सुखी रहें, निरोगी रहें, एक दूसरे की सहायता करते रहें. और रेजिडेंट्स के लिए एक ही सलाह है कि सर्जन कैन बी फिजिशियन, फिजिशियन कैन नॉट बी. तो आपको मेडिकल मैनेजमेंट में सभी चीज़ों का आना चाहिए. Work hard and be devoted to your duty, be sincere to your duty. Thank you very much. God bless you all. Thank you. Jai Hind.
Thank you, sir. May I now request on the podium the guest of honor, Professor A.K. Tripathi, sir, who is also the Dean Medical and Presiding Officer to Honorable Vice Chancellor, sir, to kindly come and share his valuable words.
Good afternoon. Professor Prabhu Nyogi, President, UP Chapter of Associations of Physicians of India, Surgeons, and Vice President of Association of Surgeons of India. Professor S.N. Sankwar, Chief Medical Superintendent, King George Medical University, Lucknow. Professor Abhinav Sonkar, HOD, Department of Surgery. Professor K.K. Singh, Chairman, Scientific Committee. And Dr. Ajay Pal, Organizing Secretary of this meeting. I'm extremely delighted to be here on this occasion of 111th Foundation Day of Department of Surgery, King George Medical University, Lucknow. This is a very memorable occasion for the department because on this occasion we pay tribute to the pillars of the foundation. We reflect, showcase, and celebrate our achievements. On the other hand, also we resolve for the future. But one thing which is very notable in this Foundation Day is that this is preceded by 4 days of very intense, immersive, comprehensive update program. So for this, I congratulate the Department of Surgery because I have not seen such kind of program in any other department of the institution. Generally, we organize half-day seminars, half-day programs, but here it is just like a mini conference. The Department of Surgery, as you have seen, has a very rich legacy. There have been very iconic personalities who have founded this department. And Department of Surgery is keeping the flags high. Each and every faculty is outstanding. They are doing excellent job. And also setting a new benchmark. What I have learned from the presentations during the last 4 days, I have gone through some of the contents. I found that many of them are improvising and innovating some new techniques which are affordable, accessible to poor people. And some of the surgeries they are doing at 1/5, 1/6 of the cost, what is, the other centers. So I cannot overstate my appreciation for the Department of Surgery. It is said that coming together is beginning, keeping together is progress, and working together is success. And this is truly exemplified, exemplified the Department of Surgery under the illustrious leadership of Professor Sonkar. He has very affable and genial personality. On the other hand, he does not compromise on the quality of teaching, training, and also the discipline. And let me give you an example. I think you don't know that. There is a deplorable situation of very poor attendance of students in the classes and clinics. As a dean, we are very concerned about that, how to improve that. So we ask student representatives from each batch to the dean's office to discuss what is the problem and how can we improve that. So there was a startling revelation from the student, and what was that, you know? They said that, sir, if you follow surgery model, things will improve. Then I thought, what is surgery model? They say it's not, they said that it's not good for them, but it's good for institution. There should be strict discipline, strict monitoring of attendance as well as regular classes. So that's how I commend the Department of Surgery for this. So I again congratulate Department of Surgery and extend my best wishes. It is one of the best departments in surgery in the country, and I hope and I extend my best wishes that it emerges as best department in the whole country. Thank you, and all the best wishes for Mahashivratri. Thank you.
Thank you for your good wishes and blessings, sir. May I now request our chief guest for the occasion, Dr. Prabal Niyogi, sir, who is also the elected president ASI and the sitting president UP chapter of ASI, and is working as professor in MLN Medical College, Agra, to share, Allahabad, to share his words of wisdom. Sorry.
Thank you. Oops, sorry. Good afternoon, dignitaries on the dais, Professor Tripathi, Professor Shankwar, good friend, Professor Abhinav Sonkar, Professor K.K. Singh, and dear Ajay Pal. Dignitaries of the dais, Professor Ramakant, my senior, not only my teacher and my senior in ASI, and the past president of ASI, Professor Anish, Professor Pahwa, Professor S.K. Mishra, great friend Dr. R.B. Singh, so many people sitting here, Arshad, Gangwar, Jiten, Kushwaha, dignitaries of the dais, faculty members, dear students. It's my proud privilege to be here on the 111th Foundation Day of the King George Medical College. I profusely thank Professor Abhinav Sonkar, who has taken this Department of Surgery to greater and greater heights with his academic mind and his scholarly attitude, and most important, the ability to take everyone together. Very much like our Prime Minister's logo of Sabka Saath, Sabka Vikas. And I think he has proven that, and that is one of the reasons why the Department of Surgery is seeing the heights that we are seeing now. My late father was a graduate from here, my father-in-law, my brother, it runs in my blood probably. Unfortunately, I couldn't make it here. I got into Armed Forces Medical College in Pune, and it is still this thing that I could not be a part of the KGMC alumnus. But anyway, I have been regaled with tales of King George Medical College since my childhood. You can imagine, everybody of my relatives from this college talked about Surgeon Mathur, how he used to come in his car and how people used to run away, Professor S.C. Mishra, and it is absolutely so many stories from the past. And it is nostalgic for me to come here and come to this university, the portals of which so many of my ancestors have walked. Founders of S.C. Mishra, as I saw the oration in his name, Professor S.N. Mathur, these were the charter members. They were premier surgeons of their times. And they were the charter members of the Association of Surgeons of India. There were hardly about 50 surgeons or 75 surgeons in the whole country. This is, I'm talking about 85 years back. We have a very long history. And these are the people who came together and formed the Association of Surgeons of India. And you won't believe, our chapter, the UP chapter of the ASI, is the oldest chapter in the whole country. 75 years back, it was the foresight of these people, S.N. Mathur and S.C. Mishra, that this chapter was formed. And this is the first chapter of the country. And we will be celebrating our 75 years in, I think, 25. It's a couple of years' time from now. The strength of this association now has gone up to 32,600. That is the latest count. We are the second largest body of surgeons in the world after the American College of Surgeons, which has double the membership of about 60,000. It is a shame that we still are at 30,000. And I request and urge, and it is my honest, sincere request to residents who are passing out to become members of this association, to make this a stronger body. You, not only it's becoming a member of the association is important, you will get so many benefits out of it. And the benefits, once you become a member, you realize how important it is to be a member of the association. Academics is the primary focus of ASI, and our flagship program is called the Regional Refresher Course. We have divided the country into 6 zones, the whole country, and each zone residents are chosen on their merit, 18 of them from every zone. They come and fight with case presentations, quizzes. They come, we choose 3 from each zone, and finally 3 from each zone into 18, take them up to the national level. At the national level, the prizes are enormous. Forget the cash prizes. The first 3 go to Japan, free of cost, invited by the Japanese Surgical Society for a 1 week or 10 days observership. Everything borne by the ASI and the Japanese Surgical Society. The next 3 go to the United States with the American College of Surgeons, the next 3 to Malaysia, the next 3 to Sri Lanka. We are also coordinating with the Royal College of Surgeons. Fortunately, right now, the president of the Royal College of Surgeons of Glasgow is a great friend of mine. We work together in the UK during our residency, and we will be collaborating from that ground as well to get. I urge Professor Sonkar for a membership for the examination for KGMC, for the MRCS examination center as well. That's my proposal to them. Ireland is there. I saw it on your slides. It's on the Ireland, so we make it further, extend it further to Glasgow and to Edinburgh as well. For young surgeons, we have endoscopy programs, we have ultrasound programs, we have an NSEP program last year, which we had 32 of these on basic science, surgical, important topics like trauma, like diseases, small important diseases, tuberculosis, ultrasounds. And there were a series of 32 lectures. Every Wednesday we have it at 9 p.m., 9 to 11 p.m. And this continued for 32 weeks. It starts in January. It's already started this year. Every Wednesday from 9 to 11. And you have the topmost people in the country speaking on that. It's people, about a panel of 4 or 5 speakers. Apart from academics, I feel an image building is very important, especially these troubled times when doctors are being maligned everywhere. We have to take it upon ourselves to do philanthropy. And not only philanthropy, it should be visible philanthropy nowadays. You have to show that you're doing work. And UP probably leads in this philanthropy. And the UP ASI, every 15 days, we have a massive camp in a remote place in Dehradun called Doiwala. And over there, it is all advanced surgery, like especially urology surgery, which people are not able to afford in the hills. On a minimum of about 70 or 80 cases are done in that weekend. And this has been going on for the last 3 years. We may not be aware of it, but we have to increase such camps. Arshad is sitting here. He has been involved in these camps, and I urge people like him to come up and do such philanthropy. Apart from this, we have other schemes, the Social Security, professional indemnity schemes. So there are we can go on and on about the schemes of the Association of Surgeons of India and how it's going to help you and how it's going to help the society at large. I will not take too much time. I'm standing between you and the lunch, so I would like to call off here. And I urge you all to join hands with us for the better future of our trainees and society at large. Thank you so much.
Thank you, sir. May I now request Professor Abhinav Arun Sonkar, sir, Professor K.K. Singh, sir, and Professor H.S. Pava, sir, to please come forward to felicitate the dignitaries. Request Professor Pava, sir, to please join us on the stage. To Professor A.K. Tripathi, sir. And Professor S.N. Shankwar, sir. Thank you, dignitaries. May I request you to be seated, please? A big burden has been taken off from the organizing secretary's shoulder. So can I request you, Ajay, to please come and deliver vote of thanks?
Thank you, Geetika ma'am. Dignitaries on the dais and off the dais, respected seniors, dear friends. First of all, on the occasion of Mahashivratri, I would like to pray to Lord Shiva to shower blessings on all of us. And as the wise saying goes, I will forever remain humble because I know I could have less. And I will always be grateful because I know I have had less. Today I take this opportunity for vote of thanks to put all my gratitude into words. Let me first and foremost, I would thank our chief guest, Professor Prabal Yogi sir. He's professor from MLN Medical College, Prayagraj, who besides being president of UP chapter of ASI and vice, is a brilliant and truly outstanding teacher, and despite his busy schedule, has found time to honor this function. It's my honor and privilege to thank Professor A.K. Tripathi sir, our guest of honor and presiding officer of this function, and Professor S.N. Shankwar sir, CMS of our university, for accepting our invitation and gracing the occasion by their presence. It's a great honor. We have great orators amongst us, Professor S.D. Maurya, Professor S.K. Mishra sir, Professor Leeleshwar Kaman sir, and Professor Anish Srivastav sir. Thank you, sir, for accepting our invitation for these orations and blessing us with words of your experience and wisdom. As I stand on this platform, I would especially thank our head of the department, sir, Professor Abhinav Sonkar, sir, for giving me the opportunity to organize this event under his able leadership and supporting me right from day one. My heartfelt thanks also goes to my unit in charges, Professor H.S. Pawar sir and Professor Avnish Kumar sir, along with Professor Suresh Kumar sir for their brotherly affection, along with the rest of the respected senior faculty members for helping and guiding me in every possible way. I also thank my colleague Dr. Akshay Anand, a genuine workaholic, and he has helped me a lot during this conference. My joint organizing secretary, Dr. Amit Karnik, Dr. Sanjeev Kumar, Dr. Geetikananda, and Dr. Pankaj Singh. In such a short time, I could not name all them, but all the best arrangements we have made for this program and the surgical education program that just finished yesterday. I am also thankful to all the delegates and the expert faculty members from all over country who attended the surgical education program for their distinguished along with the distinguished invitees and dignitaries. I also thank my postgraduate residents who have ensured their presence in the surgical education program along with timely performance of daily clinical tasks. I am also thankful to all the non-teaching staff, nursing staff and employees of this surgery department who have worked hard to make this event a grand success. I thank from the bottom of my heart the companies and the representatives who have participated in the surgical education program and this function, and the electronic print media as well for their role in covering the event on day-to-day basis for the last 5 days. And also I am thankful to the catering team, decorating teams, supporting team and the clerical staff including Mr. Dharmendra Pandey for scheduling and maintaining the program. I am thankful to those whose names I might have missed but who have worked behind the screen and supported me throughout this 5-day event journey. And last but not the least, I must not forget to thank my family, my wife and kids for their continued encouragement, support and allowing me spare time to successfully organizing this 5-day event. Thank you everyone. I once again thank everyone for making this program successful. Thank you.
Thank you, Ajay. And now we end the ceremony with the national anthem. But I request all the residents and the faculty members to kindly stay back because we'll have a group photo with the dignitaries and afterwards we can proceed for the lunch at the VIP parking area. So I request everyone to stand up for the national anthem, please.
Janagana mana adhinayak jaya he Bharat bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga Tava Shubha Name Jage Tava Shubha Ashish Mage गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all. I request the dignitaries of the stage to please come up and all the residents to please come up for the group photograph.
सारी फैकल्टी ऊपर आ जाइए जल्दी से. रेजिडेंट प्लीज स्टे करें. एक बार हम फैकल्टी तक खिंचवा लें फिर हम लोग. रमाका सर आप बाहर कपड़े तो नीचे खड़े हैं. सर आ जाइए. आप लोग आइए प्लीज आइए. आप लोग आ जाइए. आइए 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 सर आइए प्लीज आइए. गंगवा सर आइए. एक बार हम लोग सभी खिंचा लें फिर रेजिडेंट लोग भी आएंगे सारे. फैकल्टी प्लीज आ जाइए.
The residents can now join, please. Please come up. मैम कैसी है? मैम इज सो